Hello, everyone. We are here at last, 1st of October, 7th ASID Conference, first online experience and first hybrid experience. Phenomenal times we've spent trying to put this together. I'm really delighted to welcome you all to our conference, both to all our online viewers and to the physical venue attendees. A very warm welcome to all of you. We tried in this conference to capture a couple of issues that worried us in Africa and specifically in ASID, because Africa is a very big continent with many communication languages and cultures and population that is growing very quickly and has exceeded 1.3 billions, with an estimate of about 1 million patients with primary immunodeficiencies. However, we only managed to capture about less than 1% of these patients so far. So ASID has worked really hard to do something about this, despite the complexity of the diseases and the heterogeneity of their varied presentations. We have tried really hard to address the reduced awareness about the primary immunodeficiency diseases, but unfortunately, this was a very tough job for all of us. And what really didn't help us even more, and what didn't help our primary immunodeficiency patients, is the distractions by the other, seemingly urgent health problems that are preoccupying the healthcare providers in Africa. So despite our activities until 2019 in the form of the meetings, the ASID schools, and the very successful A project, which was launched in 2013, and launching, warning signs that are special to Africa and more relevant to our settings. And despite the extensive collaboration with our long-term partners in IPOPI and INGID and our sister societies through the IAPIDS Alliance, I mean, things have started to ease a little bit, but unfortunately, we still were stuck at this less than 1% pickup rate. So we felt that we needed to review all our strategies and see how can we help this situation, if we can introduce some new tools or new methods, or perhaps revamp some of these to improve the pickup rate for our patients, and to see if Africa has actually got a different profile of primary immunodeficiencies, perhaps underlying this very low pickup rate. So to address all this, we had two main thoughts. So the first one has been a long-term one since the beginnings of ASID, when we were thinking about how can HIV tools, for example, help the pickup or the diagnosis of patients with primary immunodeficiencies within the limited resources of Africa. So now we have elaborated this a little bit further to see if we can find any primary immunodeficiencies hiding among patients who have some of these endemic diseases. We also thought about the other portion of diseases, or the other side of the coin, which included all the well-known monogenetic diseases, which are also on the the very fast increase and which have been defined by the IOIS through its classification, as well as by its phenotype through the phenotypic classification. So to address these main thoughts, I will just highlight, how we approach the endemic diseases issue. we felt that there are many opportunities to see if there are patients hiding in the endemic diseases group because basically these are national and continental priorities. So perhaps we can convince authorities and individual country organizations can actually make good statements and cases for more funding towards this kind of research and also to make use of what's available in terms of facilities for diagnosis and management for this group of patients. And there we had a proof of concept through what I have already mentioned, what we've been using throughout the past years in terms of using the HIV resources in boosting PID diagnosis in Africa, which has succeeded in many African countries, but not all of them. And other proof of concept came from the very successful genetic research that South African group have done through, just using SPARE criteria and then on TB patients and then running NGS, thus confirming that 36% of their cohort actually had, a PID of some sort, which is related to TB susceptibility, which is related to the genetic susceptibility to tuberculosis. So we are now exploring further opportunities here to see if we can find, to carry on with the TB diagnosis and genetics, as well as to see if we can explore more complex diseases such as malaria and visceral leishmaniasis. So we have a very big 3-component kind of session to deal with this on day 2, that's tomorrow. The other thought that crossed our thinking and preoccupied us over the past year is whether we can actually help our low-income countries within Africa with their endemic infections in developing, in picking up I would say the classic kind of monogenetic PIDs, which have already been defined through using Africa-relevant kind of guidelines. So this was one of our new projects to develop African clinical guidelines, which match the IOIS phenotypic classification and which use available resources and which we hope will lead to an ASID registry. We will see a lot on that, and I'm really excited about this project in the second day as well. Well, we hope that through exploring these two venues and modifying our methods further, we really hope that we will improve the pickup rate and see more patients receiving better care. And we also hope that we will have better collaboration with our friends, we'll have better centers. So I'm really hoping that within the coming 5 years or so, we will have a big development in the area of PID in Africa. Now the preparation for this conference, I have to say, was a phenomenal experience, and I'm really excited that we are here together today. It's just amazing. And I cannot underestimate nor pretend that any of what you will be seeing or experiencing could have been done without the help of so many people that you know and many more who you don't know and you wouldn't be able to see. I'd really like to thank and acknowledge all our partners in Sudan, the Sudanese Society for Clinical Immunology and Allergy, and the Sudan Medical Specialization Board, because in the last minute, they managed to pull together a hybrid venue for physical attendance of our Sudanese delegates. And I really hope that this will also make a major development and a leap in the quality of management of our patients of PID in Sudan. I would like to thank our partners at IPOPI and the Sudanese and SOPI, which is a Sudanese associate organization for the patients with IPOPI. Would like to thank INGID for their readiness to come into this meeting, and also the Hereditary Angioedema International organization and our sister organizations within the IAPETS umbrella. My ASID board fellows, I can't thank you enough, and I mean, it's been a phenomenal round. I'm really indebted to all of you. Members of the organizing and the scientific committees, all our speakers and moderators, you've just been phenomenal. Again, the SMSD headship, they've just given us everything that they could give to do this the right way. The team from our Sudanese society, and I can't not mention our patients and our great Mr. Omar Al-Azraq, who has been just phenomenal looking after the platform and answering all the questions and educating me with all I needed to know with social media and that. So thank you very much to all of you. I'm really indebted. This work wouldn't have been possible without the phenomenal and generous sponsorships from our platinum sponsors and from our other sponsors who devoted a lot of time and energy and support, not only their money, but you know, these people have just been phenomenal. They were really involved in each and every step of the way. Thank you very much to all of you. And finally, I would just like to say to our local delegates at the physical venue, enjoy your time, make use of all the experiences that you will have here. And I am sure you can make a big change to this group of patients. You will learn a lot about their difficulties in Sudan. And I really hope that more collaborations will happen through contacting local offices for WHO and the Ministry of Health to make the life of our local patients better, as well as collaborating with other centers in Africa and in the world to bring together much better care for all of our patients in the world. Thank you very much, everyone. And thank you to all of those who have worked tirelessly and selflessly behind the scenes. Thank you so much. I'm really delighted today to let you know that we are being joined by our INGID and IPOPI heads, chairpersons, and they will be delivering their speeches straight away, starting with INGID president. And then I would also like to draw your attention that you can ask all your questions for the coming sessions on YouTube. Well, thank you very much for your patience. Thank you.
honored organizing committee, honored delegates. On behalf of the International Nursing Group for Immunodeficiencies, INGID, and the INGID board, it is my pleasure to welcome you to the 7th ASID Congress. We are proud to be part of the Congress and to be given the possibility to share some of our nursing knowledge regarding treatment and care of children and adults with primary immunodeficiencies. Practical examples of immunoglobulin replacement therapy and home therapy will be given during a presentation tomorrow by my colleague, Professor Dr. Anne Gardel, Senior Research Nurse Sarita Workman, and Pediatric Specialist Nurse Gabi Strothman. We know that living with a primary immunodeficiency affects all parts of a person's or a family's daily life, school, work, interaction with other children and adults, and social and leisure activities. Therefore, it is so important that we all, physicians, patients, families, patient organization, and nurses work together to raise the awareness for primary immunodeficiencies in our societies. We need to do this to find children and adults presenting with an impaired immune system to be able to help them to be diagnosed and thereby receive treatment and care. We know from research that treatment significantly improves patients' and families' health-related quality of life. When it comes to replacement therapy with immunoglobulins, we know that it is not the least the possibility to self-infuse at home that improves the life situation for the patients and the families. To educate and train patients and parents for self-infusing immunoglobulins at home is one of many important nursing activities. It cannot be said enough how important a congress like this is to achieve our common goals, where we all pray for a better health for our patients. We would like to extend our warmest congratulations to the organizing committee. The Congress is a success already with so many delegates from many different countries. Thank you. And I give the word now to the IPOPI delegate. Thank you.
Thank you, Patricia, for this kind introduction. And I am Martine Perjean, the president of IPOPI, and on behalf of IPOPI, I have great pleasure in welcoming the participants to this joint 7th ASID IPOPI INGID meeting. For sure, I love the title of this Congress, PID in Africa, where and how to find them. This says it all. In a continent of 1.3 billion inhabitants, we know that we have close to 1 million patients. Where are they? So this Congress is an absolute need. And I would like to congratulate the organizers for their hard work in preparing it, especially in the COVID-19 context. The program looks fantastic and the attendance amazing. Many physicians, scientists, and many students as well. This raises hope for the future of PIDs in the region. Many countries in Africa are making great strides in diagnosing and treating these patients. But much remains to be done. And dear Nahla, I was very interested in ASID's willingness in following the track of endemic diseases hiding patients with PIDs. And you can count on IPOPI to partner with you in raising awareness and advocating for these genetic non-communicable diseases. This is a long process. It must face the lack of knowledge, the lack of means, and even stigmatization. But each country can progress through the joint efforts of doctors, patients, and nurses working together. To patients, to parents, I'd like to say, don't rely solely on your doctors so your conditions are taken into account by health authorities. We need you all as groups, as strong voicing groups. To physicians and nurses, I'd like to say patients can be of great help in the fight for access to diagnosis and treatment. Don't hesitate to empower them when they are willing to engage in patient groups activities. For sure, we need to collaborate, communicate, and advocate all together so that health authorities get aware of their situation, understand that treatment exists and that lives can be saved. At the IPOPI meeting, we will work on this. We will learn from the experience of the most advanced countries from the region. We will see the benefits of acting together and identify possible actions for the sake of our children, for the sake of adult patients, as well as PIDs are not only pediatric conditions. I am more than happy to share with you that we will welcome around 25 patient delegates coming from 10 different countries, and some of them in Sudan, in presence in Sudan, which is great. And I'm sure that thanks to this meeting, we will even increase the interest in cooperation and in patient groups. I'm happy to say you all again, even if I much regret not being able to really be in Khartoum, a big thank you to the organizer again for their hard work, and let's roll up our sleeves and look to the future with hope and confidence. I wish you all an excellent conference.
At the heart of the world, Sudan occupies an excellent location within the African continent. It has vast arable land estimated at over 200 million fedans. With various climates ranging from the desert in the far north to the equatorial in the south. Thus, securing good climatic conditions for an economic integration characterized by a multitude of agricultural production seasons. The Nile alone provides a feasibility study for investors and businessmen to make use of its magnificent banks, its turns and contours, its waterfalls, starting with the 6th waterfall in Sabaloka area, the 5th waterfall in Karba area in Nahr Nil, down to a number of other waterfalls, up to the edge of the Lake Nubia, touching the high dam peripheries. 7,000 years ago, this land witnessed the birth of the great civilizations, Karma, Nabda, and Marawi. As it was and still is, a crossing point and link and passageway. Countless religions coexisted on its soil, divine and other religions. Migrations from various parts of the continent lived and coexisted from East Africa, from North Africa, and from West Africa, as well as from the Arab Peninsula and from Asia Minor up to Europe. This made the country rich with ethnic grouping different races and varied cultures, multitudes of languages, rich customs, diverse tunes, and colorful dances. Sudan is the leading producer of gum arabic worldwide. It produces some 70,000 metric tons of gum arabic, of the highest preferred quality. This is 75% of the world production. sits on a huge animal wealth estimated at over 100 million heads. It hosts some of the largest natural reserves in the world and enjoys rare natural wealth of different fauna of wild and domesticated animals, grazing in unspoiled flora, a green coverage extending as far as the eye could behold, in a multitude of areas which are pregnant with countless potentials. To that is added treasures of wild birds, poultry, and fish of various types that meet local and international market requirements. It stands out as an important center for food security here and as far as the eye could see, and in all regions of the country are herds after herds of the Sudanese cattle that are of the pure Asian zebu species, as well as hybrid with African species, the Bagara, Kinana, Butana, Frisian cattle, and the Nilotic Zebana species, and a multitude of other species that are raised along the bank of the ancient rivers, with each species standing out for its meat, milk, or hides produced. Sudan's annual gold production stands at 200 tons. Sudan has been historically linked with gold, and gold production since ancient times as cited by historical records. Estimates say the Sudan sites on the third largest uranium reserve all over the world, and the largest reserve in copper as well as other minerals such as chrome and iron. Demographically, Sudan is a young nation. As demographic surveys say, 65% of its population of 40 million people are less than 40 years of age. This is an indication of a promising future, considering that the most of its resources, both on and underground, have not yet been exploited, to the exception of 10%. The future appears much brighter for the country.
You can go.
Yes. Okay. Hello, everyone. It's my great pleasure to start this session. I'm Rida Barbouche from the Pasteur Institute of Tunis, and I'm pretty much pleased to co-chair this session with my colleague and friend Ahmed Aziz Bousfiha from Morocco, who, as you may know, started all this initiative of the ASID in 2008 in Casablanca. It was a great meeting, and I'm pleased. I'm really very happy to see that this society is growing and is still. Hello, everyone. It's my great pleasure. And is still progressing, as you can see.
You can continue, please.
Hello? Hello? Yes, I'm sorry. There was some interruption. So as I was saying, I'm really pleased to co-chair this session with my colleague and friend Aziz Bousfiha, who did start all this ASID initiative in 2008 in Casablanca. And I see that this society is growing, and this is a great pleasure for all of us. We are really relying now on these meetings to keep in touch with one with the other, and we have been starting some collaboration. That's really great. So without any further delay, I give the floor to Aziz to introduce the first speaker and maybe to give his speech. Thanks, Aziz.
Many thanks, Rida. I am very happy to be with you, and perhaps with Maroufou Alaou from Benin. Perhaps he will join us. So I am very, very happy to introduce my colleague and great friend, Professor Shereen Reda, who is, as you know, an ASID founder from the ASID in 2008 in Casablanca. Professor Reda is a professor of pediatrics. She is currently the head of pediatric allergy, immunology, and rheumatology units of the Children's Hospital of Ain Shams University in Cairo, Egypt. So she will talk about schematic approach to child with suspected PID, as you know, called now IAE. And please, Professor Shereen Reda, you have 20 minutes and to let 10 minutes for the discussion. Welcome, Professor Shereen Reda.
Bismillah ar-Rahman ar-Rahim. Welcome all. First of all, I'd like to thank Professor Nahla Aywa, President of the Congress, and the organizing committee for inviting me to participate in this valuable Congress. In the next 20 minutes, I'm going to talk about the schematic approach of a child with suspected primary immune deficiency. I have no financial disclosure or conflict of interest with the presented material in this presentation. Inborn errors of immunity, also known as primary immune deficiency diseases, are a heterogeneous group of, to some extent, rare genetic disorders of the immune cells. These disorders manifest with various clinical phenotypes, including infection, allergy, autoimmunity, autoinflammation, and malignancy. And in the last publication of the International Union of Immunological Societies Expert Committee, now we have 430 different gene defects that are distributed along 10 categories. The first is combined immune deficiencies. Then we have the combined immune deficiencies with syndromic features, predominantly antibody deficiencies, diseases of immune dysregulation, congenital defects of phagocyte number or function, defects in intrinsic and innate immunity, autoinflammatory disorders, complement deficiencies, genes that cause bone marrow failure, and last, the phenocopies of inborn errors of immunity. And if we look at the distribution of cases among these different categories, we can see that this data is collected worldwide from the specialized societies like the ASID, the LACID, the UCID, and some records from several parts of the world like Asia, Africa, and Australia. We can find that the predominantly antibody deficiencies still constitute 55% of cases. And then we have the other well-defined immune deficiencies, the combined T and B cell, the phagocytic or congenital phagocytic defects, and complement. And all in all, about 93% of patients present with infection. So in my talk, I'm going to focus on 3 points. First, when to suspect inborn errors of immunity. And then I'll talk about the clinical features of common IEI, and finally, the laboratory evaluation that is needed to evaluate a patient with suspected IEI. So when to suspect IEI? First, we have the warning signs, and these are adapted from the 10 warning signs provided by Jeffrey Model Foundation Expert Committee. We can see here that the family history of immune deficiency or unexplained early death, together with failure to thrive or gain weight, are very important, and infections with all kinds. You have recurrent infection, severe infection, persistent infection, or uncommon or common pathogens that can affect any part of the body, together with the poor response to antibiotics. These infections are difficult to treat. Usually they do not respond to the oral antibiotics, and the need for intravenous antibiotic to clear infection is usually happens. Then we have the autoimmune manifestations, especially in the very young child. If we look at the clinical features based on the age at onset of symptoms and the laboratory findings of some common IEI in our continent, here we can divide the occurrence of the different diseases of primary immune deficiency according to age. Some of these diseases manifest early in life, from birth until the age of 6 months. We have the Omen syndrome and other combined immune deficiency and severe combined immune deficiency as well. And usually they have this form of lower respiratory tract infection, the GIT infection, skin rash, failure to thrive, and with the characteristic lymphopenia. Then we have the severe congenital neutropenia with severe bacterial infections, the DiGeorge syndrome with the facial features that are characteristic of DiGeorge, together with absent thymus and cardiac defects. We have the leukocyte adhesion defects, in which we get infection and huge abscesses with no pus formation, and sometimes we get delayed separation of the umbilical stump. Then we have the CT40 ligand deficiency, in which we have here infection everywhere, especially in the GIT with cryptosporidial infection ending with sclerosing cholangitis, and the hemophagocytic lymphohistiocytosis disorders with fever and pancytopenia, and the characteristic high serum ferritin. Then we have, at the age of 6 to 12 months up to 5 years, we have the group of predominantly antibody deficiency, the hypogammaglobulinemias, and the Wiskott-Aldrich syndrome, which is characterized by the infection, severe eczema, together with bleeding tendency, and there is microthrombocytopenia in the lab. You get the chronic granulomatous disease with the lower respiratory tract infection, the abscesses, and the granuloma everywhere in the skin, the lungs, the bone, the GIT. Then we have the complement deficiency infections, meningitis, abscesses. You get the early onset autoimmunity like the immune deficiency, polyendocrinopathy, enteropathy, X-linked, the IPICs, and the inflammatory bowel disease, with the appearance of the other endocrine affection, like you get diabetes or you get the thyroid affected, together with hepatosplenomegaly and gastrointestinal manifestations. We have the hyper-IgE as well with eczema, lower respiratory tract infection with the characteristic staph, pneumonia, and the matoceles, with the coarse facial features and the skeletal anomalies. And last, the Shidiak-Higashi syndrome with partial albinism, nystagmus, motor delay, and infections. After the age of 5 years, some of the diseases start to manifest, like the common variable immune deficiency with sinopulmonary infection and granuloma. You get the ataxia telangiectasia and DNA repair defects, and we get the selective IgA deficiency, and any of the above can happen after the age of 5 years, except, of course, the severe combined immune deficiency, and these represent a late onset variant of the disease. If you look here, we can find that there is eczema, the upper left side, together with the delayed shedding of the milk teeth in cases of hyper-IgE. You get the oral moniliasis here in patient with severe combined immune deficiency, or the partial albinism in Shidiak-Higashi, the telangiectasia of the sclera, and the hyperpigmented areas on the skin in patients with ataxia telangiectasia, and the severe oral ulcers in severe congenital neutropenia. We have a huge abscess here with no pus aspirate, indicating leukocyte adhesion defect. Maybe get the ulcer at site of BCG enucleation, and this is with the rash represent the BCGiosis, and we have the abscesses everywhere in the body, huge abscesses, and maybe minor abscesses on the body represent whether a chronic granulomatous disease or complement deficiency. Imaging studies would help too to identify patients with primary immune deficiency. If you get a patient and you have a look at the chest X-ray, you can see sometimes the chest representing a morbid chest. Here you get the dissemination of the BCG, you can see it here, or you get the granulomas of the lung, or you get a severe form of consolidation with lung fibrosis, and you get the abscesses or the nematoceles here. Sometimes we see the bronchiectasis, which reflect a chronic respiratory tract infection, or we may find in the lateral view in the superior mediastinum, you get absent thymus. Also, we can have the overcrowded teeth of the hyper-IgE in the panorama. So what to do after we have a thorough history taking and clinical examination? We do the immunological tests to support our diagnosis and to verify the disease. Let me tell you that inborn errors of metabolism, the diagnosis here is mainly laboratory. So we start with the basic tests, and the basic tests include the complete blood count with differential, the total serum immunoglobulins, delayed hypersensitivity test in vivo by tuberculin test and candida skin test. Then we have this, the second step depends on the results of step 1. We do the flow cytometry analysis. The panel, the normal panel we have is to detect the B cell, the T cell, and the natural killer cell. Then we go to the phagocytic test for the function of the phagocytes, like the oxidative burst. We do the nitroblue tetrazolium test and dihydrorhodamine test. And for the leukocyte adhesion defect, we get the CD18, CD11, and the complement assay. And then we move to step 3. And this step 3 is usually carried out at a specialized center because they do the functional testing of immune cells and molecular genetics. So let us here see if we have a patient suspected to have combined T and B cell immune deficiency or others with recurrent infection, bacterial, viral, fungal, and presenting early in life during the first 6 months of life. Then we do the basic test, and if we have lymphopenia with absent delayed hypersensitivity test, all the immunoglobulins are very low, and we have negative HIV testing, then we do the lymphocyte subsets. And if we have a very low CD3, this indicates that this patient has SCID, and we do the immunophenotyping, and of course later we do the molecular genetic testing. Meanwhile, if we don't have lymphopenia that much, or just slight lymphopenia or no lymphopenia with variable levels of immunoglobulins, you get high, for example, high IgM and low IgG and IgA, So we move to the lymphocyte subsets as well. And if the CD3 is normal, but we have CD4 low or CD8 low or low CD19, then we start to do the in vitro T cell function and T cell proliferation and to study the surface or intracellular protein evaluation of CD40 ligand, of the others. And these are carried out in the specialized center, and we move to the molecular testing. The SCID immunophenotyping can be identified by the presence or can be classified according to the presence of absence of the B cell and natural killer cell. We have from the start no CD3, so we get another and to see what about the CD19 of the B cell and the CD56 of the natural killer cell. And if all are negative, then we think of adenosine deaminase deficiency or the reticular dysgenesis. If the B cell is negative but the natural killer cell is positive, then this is RAG1 or RAG2 deficiency and the Artemis deficiency. If the B cell is positive and natural killer positive, this is an interleukin-7 receptor alpha deficiency or CD45 deficiency. If the B cell is positive and the natural killer cell is negative, then this is a common gamma chain, which is X-linked, and the JAK3. Meanwhile, if we have recurrent bacterial, fungal, and specific viral infections, like you get the enteroviruses, for example, like the poliovirus, and we suspect B cell from the onset of symptoms after the age of 6 months, and then you suspect B cell phagocyte or complement disorders or others, we do the basic test, and then if we have a normal CBC, no abnormality in any of the cells, but we have low immunoglobulins, and we do the B cell, the CD19. If the B cell is absent, less than 1%, this is the A-gamma globinemia, whether X-linked or autosomal recessive. If there is normal B cell count or more than 1%, but low or normal, then we suspect to have a transient hypogamma globinemia of infancy if the age is less than 3 years. If the age is more than 6 years, then we suspect common variable immune deficiency and proceed into investigation. And if we may have X-linked lymphoproliferative disorder, which usually manifests with hypogammaglobulinemia following Epstein-Barr virus infection. Or if we have the low IgA but normal or high IgM, then we suspect the hyper IgM syndrome. And then we may have a selective deficiency of one of the immunoglobulins, like the low IgA, so the case may be selective IgA deficiency. And then we do the specific antibody response to vaccine. If it is absent, then this will support the diagnosis of common variable immune deficiency. And if we have the facilities to do the IgG subclass evaluation, will be fine. Then we go to molecular and genetic studies. Meanwhile, if we have normal serum immunoglobulin levels and abnormal neutrophil count, the neutrophil count is very low. We have neutropenia, severe neutropenia, then this indicates severe congenital neutropenia. If we have the neutrophilia, then we do the adhesion molecule, the CD18, CD11 assay for the leukocyte adhesion defect. And if we have all normal, the serum immunoglobulins, normal neutrophil count, no neutropenia, no lymphopenia, then we have two options, either the respiratory burst, so defects indicating CGD, chronic granulomatous disease, so we do the nitroblue tetrazolium test and the hydrorhodamine. Or we may have this, and the second option is complement deficiency, so we do the complement assay, the CH50. Sometimes we get, from the very early beginning, we get the normal CBC, normal immunoglobulins except high IgE, so we suspect here the hyper IgE syndrome. The last thing is when to suspect autoimmunity, immune dysregulation in inborn errors of immunity. First, we have the cytopenia. This is an early onset of cytopenia. You get autoimmune thrombocytopenia or autoimmune neutropenia, and there is early onset inflammatory bowel disease, or you get the accumulation of multiple autoimmune manifestations with age. Sometimes autoimmunity starts during the course of primary immune deficiency, or may be the first presentation of the patient to present with autoimmunity, and later on we discover that they have immune deficiency. And if there is family history of immune dysregulation, and the affected patients usually present with fever, periodic fevers, or skin rash like urticaria, vasculitis, or purpuric rash, systemic inflammation, and variable arthritis and lymphadenopathy. The underlying IEI can be identified by molecular genetics. So to sum up, to wrap up what I've said, is the diagnosis of IEI can be missed if not suspected. We have to be very vigilant while examining any patient with infection. Most categories of IEI can be identified by careful history taking and clinical examination together with basic laboratory tests. Early referral to a specialized center is very important to carry out the advanced immunological tests that are not available everywhere in every hospital or every center, and to carry out the genetic testing to provide proper management. And lastly, I'd like to thank my dear colleagues at the Pediatric Allergy, Immunology and Rheumatology Unit at Ain Shams University, the place where I work. This unit was founded by my late Professor Yahya Al-Gamal, my role model, my teacher, and I wish his soul rest in peace, and my other colleagues, which I wish them all the best and success, and thank you very much.
Hello again. I am very happy to present my colleague, Professor Nermeen Galal from Cairo University. She's a professor of pediatrics. She actually leads the PID unit of Cairo University, specialized pediatric hospital. Professor Nermeen Galal will present a talk about PID in neonates, early diagnosis and management. Professor Nermeen Galal, you have 20 minutes and to let 10 minutes for discussion. Welcome, Professor Nermeen Galal.
Thank you, Dr. Busfiha. Thank you. Good afternoon. Happy to be with everyone in spirit. In this presentation, we'll focus on the neonatal period, get to know which PIDs commonly present in the neonatal period, what do they present with, when to suspect them, how to diagnose them, and talk about the management outline. Any newborn transitioning from a sterile environment to a microbial-rich environment may get bombarded by all sorts of pathogens and may acquire an infection. And there are other factors that favor the occurrence of infections, like some anatomical characteristics, like having a thin skin or impaired pro-inflammatory cytokines or diminished cell-mediated immunity, whereas there are other factors that oppose the happening of infections, like the maternally transferred IgG, intact innate immunity, and other adaptive mechanisms. So any newborn may develop an infection, but we're more concerned with those who develop spur infections, as we just heard in Dr. Shereen's presentation. And whenever a newborn develops an infection, the question will remain whether this is an immunological immaturity or a true underlying PID. Infections are not the sole presentation, but autoinflammation may be the presenting features, as with NOMID, where babies or newborns may develop very high fevers, lasting fevers with organomegaly, joint affection, and rashes. Or autoimmunity may also be the presentation, like within neonatal diabetes in disorders of immune dysregulation. Allergy may also be a presenting feature, although allergic disorders need time for sensitization to occur. However, patients with DOCK8 deficiency may develop extensive neonatal rashes. And syndromic features may also be the presenting feature for some of the newborns. So which PIDs commonly present in the first 3 months of life? Actually, the class of SCID combined syndromic disorders is the most common or the prototype of PIDs in the neonatal period. You have the SCIDs, the Oman, the DiGeorge, Wiskott-Aldrich, or DOCK8 deficiencies. Some of the phagocytic disorders, like the CGD, the severe congenital neutropenia, LADS, may present early. Also, some of the immune dysregulation disorders like IPEX, HLH, and very early onset IBD may present in the neonatal period. In an interesting study published this year by Zhu et al., they recruited newborns with severe bacterial infections in NICUs and tested them for underlying genetic disorders. They got a yield of around 34%. And among the PID disorders diagnosed, the most common was the class of combined immune deficiencies with associated or syndromic features, followed by that of diseases of immune regulation. You can appreciate the colors in blue and green. So this is the prototype of a newborn presenting with a PID disorder, the SCID, or the severe combined immune deficiency. This case was born to consanguineous parents, a male, and he was day 24. He has a family history of SIB death with pneumonia and skin lesions. Soon after birth, developed an unresolving pneumonia, as you can appreciate in the X-ray. Severe candidal infections, unresolving or persistent diarrhea, and the leukocytic count ranged between 1,800 and 2,900. He was severely lymphopenic. Absolute lymphocytic count was 562. On testing, he was proved to have very low immunoglobulins, and by flow cytometry, all CT classes were low. And given the diagnosis of a T negative, B negative, NK negative SCID, this baby was fully matched, luckily, with his brother and underwent hematopoietic stem cell transplantation and immune reconstitution followed. So does this automatically mean that whenever you have a newborn presenting with an infection and lymphopenia, this equals the diagnosis of SCID? The answer is no, because lymphopenia may naturally occur with severe infections, or it may happen with lymphopenia of prematurity as a part of maturation, and it may follow prenatal steroid use. So how to differentiate, or whenever we have a newborn with lymphopenia? The answer is this newborn must be screened. And to differentiate, you have to acquire detailed family history, as we'll get to in a second, and then clinical examination. This baby needs to be screened, and unfortunately, none of the countries in Africa has a universal applied screening program. What we use for screening is, or what is used worldwide, is the TREX and CREX assay, the T-cell receptor excision circles, which are fragments of DNA that are obtained during T-cell development and reflect low numbers, reflect the T-cell defects. Also, CREX are able, or kappa-deleting recombination excision circles, are also able to detect the development of B cells. So not only those TREX and CREX are able to pick up patients with SCIDs and A-gamma globulinemia, but in studies have been proved to pick up patients with DOCK8 deficiency, ataxia telangiectasia, Behr lymphocyte syndrome, Nijmegen breakage syndrome, or Wiskott-Aldrich syndrome. If the screening test comes out normal, you do not need to do a further action for now. You may keep the patient under follow-up, definitely, but if the results are abnormal, you need to confirm them by further tests like flow cytometry tests, testing for naive and memory T cells, and proliferation assays. Looking at the other side, can it happen that we get a SCID baby with normal lymphocytes? The answer is, again, here, yes, because Omenn syndrome may present with normal lymphocyte count, with lymphocytosis on the other side. You may get a SCID with normal lymphocytes if maternal engraftment with T cells happen, or if this is a case of MHC class 1 or 2 deficiency, or with disorders where there is clonal proliferation of T or B cells. How do we differentiate? By looking for naive T cells if they are low. If you're thinking of engraftments, you may test by VNTR or FISH, and testing for the HLA-DR expression, the CD4 and CD8 subsets, and proliferation assays. Other syndromic features may alert the physician or raise suspicion, like in DiGeorge syndrome, where you have a baby presenting with congenital heart disease with dysmorphic features, which may be subtle, with hypoparathyroidism and or cleft palate, and is diagnosed by FISH analysis. Wiskott-Aldrich may also present in the neonatal period by the known triad of diarrhea, eczema, and thrombocytopenia, but patients may develop splenomegaly, may have persistent fever, may present with post-circumcision bleeding, so they need to be tested. And this is another example of a baby presenting in the neonatal period with history of male SIB death at 6 months with pneumonia, and an affected female SIB with an onset of 3 months, but this baby started at 1 month of age. She was born to a consanguineous family. And as you can see, she has multiple swellings involving the right elbow, right hand, and fingers, and a large right axillary ulcerating swelling with generalized pustulosis and late neonatal sepsis and a perianal abscess. And she was given the diagnosis of chronic granulomatous disease after being tested by dihydrorhodamine assay and confirmatory testing. Another example is a male born to a consanguineous family with, again, a family history of female SIB death at the age of 7 months with pneumonia and sepsis. He presented at day 29. He has history of falling of the umbilical stump at day 25. He developed omphalitis and umbilical hernia, had pneumonia and severe sepsis. And you can appreciate in his test the low hemoglobin and the very high leukocytic count, which mounted to 101,000. On testing, after suspicion of leukocyte adhesion deficiency, the diagnosis was confirmed by very low CD18 and CD11B markers. Now we come to the disorders of immune dysregulation. For example, IPEX may present with, again, family history of affection, as you can appreciate in the males. Here, the baby presented with diabetic coma, neonatal diabetes, thyroid autoantibodies, alopecia totalis, nail dystrophy, as you can appreciate in the lower picture, and a watery diarrhea with hypoalbuminemia and elevated liver enzymes. You can appreciate in the picture the rash on the lower limbs as well. Another presentation might be the presentation of hemophagocytic lymphohistiocytosis. Again, this was a male newborn born to a consanguineous family with history of male SIB death. And the presentation was fever, generalized maculopapular rash, organomegaly, sepsis, pneumonia, which necessitated mechanical ventilation. The baby developed pancytopenia, as you can see, with high triglycerides, high ferritin, and low perforin expression, giving the diagnosis or confirming the diagnosis of HLH. Sorry for that. Another presentation can be of that of very early onset IBD. This is first SIB, a female born to consanguineous parents. At 1 week of age, developed fever with persistent crying. A few days later, stool started to pass out of her vagina, giving the diagnosis of a rectovaginal fistula. She was operated upon and was found to have several fistulae later on, with severe bloody diarrhea and dehydration, failure to thrive, mouth ulcers, and gingivitis. And endoscopy revealed severe duodenitis, ileitis, colitis, and several fistulae. As you can appreciate in the photos, the picture of a serpentine colonic ulcer. Giving the diagnosis of very early onset IBD, molecular testing revealed IL-10 receptor B deficiency. Now you've seen the different presentations that may actually occur in the neonatal period. We come to the family history. And family history, when we ask about it, we do not just ask about similar presentations or individuals with similar presentations. We have to ask about unexplained deaths. We have to ask about individuals with severe infections, with autoimmune disorders, especially if multiple, with malignancy. And we have to ask about the pattern of affection, whether this involves male SIBs or just giving an autosome X-linked disorder or more of an autosomal recessive disorder. We have to test or ask about pattern of infections. Another clue may be the abnormal response to vaccination, like with BCG. If a patient with SCID is given BCG, they may develop BCGosis or BCGoma, as you can see in the picture, with an axillary swelling. Or they may develop acute flaccid paralysis if they develop the Sabin polio vaccine, for example. Extensive skin lesions can be your clue, as you can see in the picture with exfoliative erythroderma in Oman syndrome, or atopic-like rash in IPEX, or petechiae and atopy in cases of Wiskott-Aldrich, where you can test and prove by the low MPV. Autoinflammatory syndromes may also present with different rashes like urticaria, pustular, or nodular rashes. What can draw your attention again to PID can be severe diarrhea and wasting, very early onset diarrhea, like in patients with SCID, IPEX, IL-10 receptor deficiency, or with Wiskott-Aldrich or CGD. And there are certain clues that you can pick up from a simple blood picture. Some hematological abnormalities, like we just mentioned, the lymphopenia that may be below a count of 3,500 or 4,000. You may think of a SCID disorder or DiGeorge syndrome. If the patient has bicytopenia or pancytopenia, you may consider HLH. If the patient has thrombocytopenia, especially with a low mean platelet volume below 7, you may consider Wiskott-Aldrich. Or if it's thrombocytopenia with other immune features, you may think of IPEX or other disorders. Leukocytosis with very high numbers that make you think of a leukomoid reaction with infections can alert you to LAD. Hypereosinophilia may be a clue to Oman syndrome or hyper-IgE syndrome. So to sum up, the 10 warning signs for PID that are more or less specific to the first year of life or the neonatal period and the early months of life are, again, the spur infections, the family history, which is a very strong criterion proved by different studies, the adverse reactions to different vaccines, autoimmune, autoinflammatory, or long-lasting fevers, extensive skin lesions, chronic diarrhea, failure to thrive, congenital heart anomalies with hypocalcemia, delayed umbilical cord separation, absence of a thymic shadow on X-ray, persistent alterations of the white cell counts, whether lymphopenia, cytopenia, or extensive leukocytosis. So early diagnosis equals improved survival, and picking up those cases as early as possible makes a great difference in their management. Unfortunately, again, we do not have the screening established on a universal level, but what we can do, or some countries started to establish targeted screening for high-risk families. And there's the reversed approach NGS, where you do not test for a marker and then confirm by genetics. You go straight forward to the NGS testing for the suspected disorders. So the situation with screening now in Africa needs more newborns to be tested, needs more cost-effective testing systems, and needs conveying to the decision makers that testing is definitely cost-effective instead of the costs that are entailed later on by the severe infections, the NICU and PICU stays, and the stem cell transplantations. And we need more accessibility for testing and diagnosis for those patients. So coming to the management, definitely the management will differ according to the type of PID, but the hallmark is you get tiers of addressing the problem, where first of all, you need to address the infections or autoimmune or allergic manifestations that are present by prevention and or treatment if you're able to establish that. Again, the second level would be targeting the immune defects, where you can provide replacement if you're able to, like with immunoglobulin replacement, with provision of granulocyte colony stimulating factor in cases of neutropenia. And then there's the third curative or corrective level of the genetic defect, where you need to establish stem cell transplantation and or gene therapy. So let's take the SCID as an example. What you need to do of combined immune deficiency, what you need is to avoid live attenuated vaccines, definitely. What you also need to do is raise awareness among residents and young physicians that those patients should not be transfused for fear of GVHD unless the blood is irradiated and absolutely indicated. You need to start them on antimicrobial prophylaxis, trimethoprim, sulfamethoxazole prophylaxis for pneumocystis jirovecii pneumonia, antifungals, antivirals, antituberculous prophylaxis if they were given the BCG before diagnosis, antibiotics whenever needed, and then you start them on immunoglobulin replacement, whether IV or subcutaneous. The curative treatment remains the stem cell transplantation, and it should be allowed for patients who are picked up by the newborn screening as a neonatal emergency, ideally before 6 months of age. Definitely, whenever the patient has not suffered several infections and does not have several comorbid conditions, and is started early on prophylaxis and in better shape, the results would be better. From whom the type of donor and the availability of donors is another issue regarding the stem cell transplantations that may happen. What is commonly used here is matched sibling donor or match-related donor or haplo donors. Haplo is kind of difficult with variable results in different disorders. And we come to having them kept in protected environment and the conditioning regimens that ideally should be kept to a minimum. So the take-home message is about PIDs in the neonatal period is that differentiation between immune immaturity and true PID or immune deficiencies is not always easy to establish in the neonatal period, but you always need to keep an open mind about PID disorders and go for screening or testing whenever you suspect a PID disorder. The most reliable criterion remains the family history with the occurrence of spur infections in the newborn. We need to get acquainted with the autoinflammation or autoimmune features that may be presenting, and we're not used to having them happen in the neonatal period, so we usually address the problem to other manifestations. Screening will always be the clue that we're targeting. If we're unable to establish it on a universal level or a nationwide level, then we should start by targeted screening for high-risk families till we prove that the numbers are not low as usually thought. And early diagnosis and management are very crucial for a favorable outcome for PIDs that start very early in the neonatal period. I thank you all for your attention. And now back to the panel. Thank you.
Thank you so much. So it's a great pleasure to continue this session by introducing my colleague and friend, Professor Brahim Belaid, who is from the medical immunology department at the University of Algiers in Algeria, and who is going to give a speech about the role of flow cytometry in PID diagnosis, and particularly the Algerian experience in his department. Thank you, Brahim, for being here. And so it's a great pleasure to continue this session by introducing my colleague and friend, Professor Brahim Belaid, who is from the medical.
Good afternoon, everyone. My name is Brahim Belaid from Algeria, immunology specialist in immunological investigations of primary immunodeficiencies. I'm very pleased to take part in this Congress. In today's presentation, I'm going to talk about the Algerian experience, especially in the use of flow cytometry as an essential tool in the diagnosis of PIDs. Inborn errors of immunity are heterogeneous group of diseases caused by defect in genes encoding proteins that participate in the immune response. They can present with increased susceptibility to infection and/or immune dysregulation and early onset of autoimmunity. Recent advances in immunology have led to the development of the novel immunologic assays, thus providing improvement in the diagnosis and treatment decision in PIDs. The laboratory evaluation of the immune system always began with a screening test such as CBC and flow cyte and serum levels of immunoglobulin, IgG, IgA, and IgM, and progressing through the indication of for more advanced immunologic testing, including peripheral blood immunophenotyping, cell maturation assessment, and specific protein expression such as BTK, FOXP3, etc., and immune cell function such as DHR and NK degranulation assays, etc., and cytokine production, cellular signaling pathways. But in order to use this complex assays, one must have a firm understanding of the immunologic assays, how the results are interpreted, pitfalls in the assays, and how the test affects treatment decision. According to the classification of PIDs, the flow cytometry-based assay can be used either in humoral immunodeficiencies, in combined immunodeficiencies or syndromic combined immunodeficiencies, also in disorder of neutrophil and phagocytic cells, immune and in immune dysregulation, etc. Let's begin with humoral immune deficiencies. The first type is a congenital agammaglobulinemia, which is characterized by low levels of immunoglobulins, low or absent of circulating B cells population with normal T cell counts and function. Congenital agammaglobulinemia can be either X-linked recessive, occurs almost exclusively in males, or autosomal recessive, and can affect both males and females. Here is an example of agammaglobulinemia diagnosed by flow cytometry with a total absence of circulating B cells and a normal distribution of naive and memory T cells. In X-linked agammaglobulinemia, in male patients, we can assess by flow cytometry intracellular expression of BTK in monocyte, but this modality does not include all mutations, only those that affect protein stability. For this reason, it is recommended to perform BTK sequence analysis. If autosomal recessive agammaglobulinemia is suspected, bone marrow analysis can be performed, were showing an accumulation of B-cell precursors identified by using CD45. Then we can evaluate their expression for some markers such as CD10, CD35, 34, CD79A, CD79B, etc. Another type, another disorder of humoral immunity is a common variable immunodeficiency. In CVID, major B cells are normal in number and morphology, but fails to differentiate into plasma cells. It is characterized by low levels of immunoglobulins and recurrent bacterial infections, sometimes some autoimmune and lymphoproliferative disorders can occur as well. Flow cytometry can be used to evaluate maturation state of B cells on the basis of IgD and CD27 expression. Most patients with CVID show a decreased number of switched memory B cells. Pay attention, decreased numbers of switched memory B cells are also observed in hyper IgM syndrome. A small subset of CVID are caused by mutation in ICOS, CD19, BAF receptor, TACI. These patients can be screened by flow cytometry. Patients with ICOS deficiency were reported to have reduced upregulation of ICOS by activated T cells. And patients with BAF receptor mutation show reduced expression of this protein, and absence of CD19 on B cell has been observed in patients with CD19 or in CD81 deficiencies. In immunodeficiencies affecting cellular and humoral immunity, SCID disorders are generally characterized by complete absence of T-cell mediated immunity. Patients with a SCID can be classified by immunophenotypic characteristic based on flow cytometry into 4 types according to the presence or absence of B cells and or NK cells. However, some patients have an atypical presentation, such as Omen syndrome phenotype, which is characterized by erythroderma with desquamation, alopecia, chronic diarrhea, failure to thrive, lymphadenopathy, and eosinophilia and hepatosplenomegaly. Almost all T lymphocytes exhibit activation markers such as CD45RO, RO, and HLA-DR, despite their highly restricted repertoire. Sorry. In combined immunodeficiency, we can also complete with lymphocyte proliferation test to assess the overall quality of their cellular immune response. In such tests, numerous activators can be used, for example, mitogens and anti-CD3 associated with anti-CD28. According to the suspected SCID, we can also assess some cell surface protein expression, such as common gamma chain in T-B plus NK minus SCID, or alpha chain of interleukin 7 receptor in T minus B plus NK plus SCID. On other hand, flow cytometric evaluation of STAT5 phosphorylation following EL interleukin 2 and EL7 stimulation can be useful to determine whether protein phosphorylation or expression of the protein is up or down regulated, and to confirm the diagnosis. Another type of kit is MHC class 2 deficiency due to the mutation in transcription factors that regulate the expression of MHC genes. HLA class 2 deficiency is characterized by a defective expression of MHC class 2 antigen on B cells and monocytes. The lack of these antigens on thymic epithelium led to incomplete maturation of CD4 T cells, leading to the decrease of immune response. Hyper-IgM syndrome is a type of a combined immunodeficiency disorder caused by a mutation in CD40 and CD40 ligand. In the X-linked hyper-IgM syndrome, the PBMC or whole blood is activated for a few hours with a mitogen. Well, in this case, we used PMA, then followed by flow cytometric analysis to examine the expression of CD40 ligand. CD40 deficiency is a phenocopy of CD40 ligand deficiency that can be identified by assessing CD40 that is constitutively expressed on B cells and monocytes. ZAP17 deficiency is a rare combined immunodeficiency with an autosomal recessive pattern of inheritance. Only 2 patients have been found in our department. This type of kid should be considered in all patients with almost or absence of CD8 T cells and NK cells, but with a normal CD4 T cell and B cell count. In such phenotype, PBMC from patient and healthy control, can be stained for surface markers, followed by cell fixation and permeabilization, and staining for intracellular ZAP17. Let's now move to syndromic combined immunodeficiencies. The first one, Wiskott-Aldrich syndrome. Wiskott-Aldrich syndrome is a rare X-linked recessive disease is characterized by eczema, thrombocytopenia, and immune deficiencies. Monoclonal antibodies against WASP protein can be used for screening patients suspected to have Wiskott-Aldrich or X-linked thrombocytopenia using flow cytometry or Western blot. Another syndromic PID is a hyper-IgE syndrome. Hyper-IgE syndrome is characterized by eczema, recurrent staphylococcal skin abscesses, and recurrent lung infection, eosinophilia, and high serum levels of IgE. Can be autosomal dominant due to the mutation in STAT3, or autosomal recessive due to the mutation of numerous mutations have been found to date. Examination of PBMC from these patients has revealed decreased in Th17, and defects in STAT3 phosphorylation were also determined in some mutations. In the absence of STAT3 phosphorylation, it will be necessary to verify the expression of the two EL6 receptor subunits, namely EL6ST, EL6LA, by flow cytometry, as we can see on this slide. Let's move to disorder of phagocytic cells. Phagocytic disorder is the result of inherited a defect of immune system. They can be divided into several groups, such as defect of neutrophil differentiation, defect of mobility, defects of respiratory burst, and defects in signaling. For severe congenital neutropenia, evaluating absolute absolute neutrophil counts by CBC or flow cytometry. It's easy to make it. For leukocyte adhesion deficiency characterized by delay umbilical cord separation, and in this situation, CD15 and CD18 expression can be assessed directly by flow cytometry. Chronic granulomatous disease is due to the lack of NADPH oxidase, which is made up of one X-linked gene and 3 autosomal recessive genes. In healthy control, normal activated neutrophils produce superoxide that oxidize DHR, resulting in increased fluorescence as depicted by shift of histogram peak to the right. CGD patient do not burst, therefore do not oxidize DHR, dihydrorhodamine. CGD carriers, usually mothers of affected male patients, will demonstrate bimodal induction of neutrophil burst, oxidative burst. Well, a patient with P47 FOX and 67 FOX deficiencies can be identified with intracellular staining using P47 FOX and P67 specific monoclonal antibodies. Mendelian susceptibility to mycobacterial diseases. Sorry, MSMD is caused by a genetic defect in the mononuclear phagocyte and TH1 pathway. In the set of strong clinical suspicion, followed by flow cytometric evaluation of interleukin 12 and interleukin 23 and interferon gamma pathway is very useful to make the diagnosis. Patient with EL12 receptor beta 1, STAT1, and interferon gamma receptor 1 deficiencies can be screened by flow cytometry. Most patients with interleukin 12 receptor beta 1 and interferon gamma receptor 1 deficiency demonstrate the absence of cell surface protein. After 3 days of PHA mitogen stimulation for interleukin 12 receptor beta 1 and without any stimulation for interferon gamma receptor 1. We can also measure phosphorylated STAT1 after interferon gamma stimulation. A decreased STAT1 phosphorylation suggests a defect in either STAT1 or in interferon gamma receptor subunit 1 and 2. Now we will discuss about immune dysregulation disorders. ALPS is characterized by non-malignant lymphadenopathy, splenomegaly, and autoimmune cytopenia as well. Patients with ALPS have a variety of laboratory findings. The signature laboratory abnormalities that facilitate diagnosis of ALPS includes the first criteria is expansion of alpha-beta negative T cells, what are detected by flow cytometric immunophenotyping. And the second criteria is defective, what a fast-mediated apoptosis assay. This test measures the ability of stimulated T cells to undergo cell death, by apoptosis using anti-FAS antibodies. Always in immune dysregulation. Here is an overview of the current diagnosis approach to hemophagocytic lymphohistiocytosis. The clinical suspected is phrased by a few elements which may require the use of the functional laboratory screening tests. In this category of PIDs, mutations, analysis remains the gold standard for the confirmation of the diagnosis. But in recent years, assays based on flow cytometry have been developed for evaluating of NK cell and CD8 T cell function. For example, degranulation assay determined by upregulation of CD107A expression is a screening test for detection of type 3, 4, and 5 of familial hemophagocytic lymphohistiocytosis. And measurement of intracellular perforin levels serve as a phenotypic assay in immediate identifying of type 2 HLA patients. Another test is the detection of intracellular SAP of SAP and XIA proteins, are useful screening tests for the identification of patients with X-linked lymphoproliferative syndrome, type 1 and type 2, respectively. Thank you for your attention.
Hello, it's now my great pleasure to introduce the next speaker, who is Dr. Brigitte Glanzmann, who is bioinformatician at the South African Medical Research Council in South Africa, and she is going to talk to us about the genetic diagnosis opportunities for PIDs, and particularly the South African experience. Thank you, Brigitte, for coming. Please.
Okay, good morning, everybody. Thank you for this opportunity. I hope it's morning when you do listen to this recording. It's been very strange to have to pre-record a talk, but I've been asked to present on genetic diagnostic opportunities for primary immunodeficiencies, specifically in the South African context. So those of you who don't know me, my name is Brigitte Glanzmann, and I'm affiliated with Stellenbosch University, the South African Medical Research Council, and the Francis Crick Institute. So we know that, I don't need to go into the intricacies of inborn errors of immunity. All of us who are here have some kind of, experience with them. But what I'd like to do is put into context how diagnostic opportunities have changed over time and how these have influenced our ability to identify mutations which may be associated with inborn errors of immunity. So the Human Genome Project ran from a period of 1990 to 2003, and over this 13-year period, we spent a lot of money and a lot of time classifying the human reference genome. It wasn't a complete version of the reference genome, but what is important is that we had a reference to work off, which meant we had a so-called healthy individual or a healthy reference that we could identify, and from that we could find out, well, from ill individuals, how do they differ? What we do know is that it was unilaterally decided across, I think, the medical and the scientific communities that it couldn't take us another 13 years or cost us what it did to identify these mutations. And that led to the development of next generation sequencing technologies. And what it does is it adds a lot of speed and a costly way to apply personalized medicine to patients. It's also changed the way we do science, because it's given us a way to analyze a number of samples fairly quickly. And should we have any questions on possible disease-associated mutations, the short answer is, well, sequence it and see how does something differ from something else. So we know that next-generation sequencing has played a crucial role in the identification of novel variants associated with inborn errors of immunity. We also know that over time, this has increased exponentially, mainly because our technologies have got better. So our means by which to identify mutations are that much easier. So according to Jeffrey Modell, between 2015 and 2017, we had a total of 85 new genes associated with inborn errors of immunity. And this was largely driven by three main facets of the next generation sequencing techniques, namely whole genome, whole exome, and targeted panel sequencing. So for those of you who are not quite familiar with the way each of these work, whole genome sequencing looks at everything in the human genome. So it looks at structural variations, it looks at copy number variations, it looks at single point mutations. But the point is it looks at everything as far as possible. Exome sequencing looks at 1% of the human genome, approximately 1% of the human genome, and only looks at regions that are in the so-called coding regions. So those regions which are responsible for producing proteins. This is particularly relevant because approximately 85% of all mutations which have been associated with various diseases have been found in these coding regions. And then the last one, and probably the most restrictive form of next generation sequencing, is the targeted gene panel, where we look at a subset of genes specifically associated with a specific clinical phenotype, and we only screen that particular gene for possible variations from what is considered reference. And so in a South African context, we have focused mainly on whole exome sequencing and the targeted gene panels. And there's a specific reason for this. Targeted gene panels in our resource-constrained settings are currently our go-to diagnostic, specifically in a clinical setting. Whole exome sequencing and whole genome sequencing are second line, and for a long time, only whole exome sequencing was available. And it's mainly because they remain research tools, and it's because of their costing and how difficult it is to interpret the data. Remember, the more data we produce, the more we have to interpret, which means it's not as easy as just, well, this gene was looked at, these are the changes in that specific gene, and these are the ones that are likely to cause disease. We also know that whole exome and whole genome sequencing need to go through rigorous proofs before they can be used in clinical settings. We know that they must have analytical and clinical validity. Clinical utility is extremely important. We need quality assurance methods, and we need rapid turnaround times. So in resource-constrained settings where we need bioinformatics to analyze whole exome and whole genome sequencing data, where we need functional validation to prove whether or not the mutation we're actually seeing in a particular gene is likely to be pathogenic. All of these are contributing factors as to why it hasn't really been feasibly applied in resource settings. And we know that genomic testing remains a considerable logistical challenge in developing countries. It's not really a go-to for a number of clinicians until the end of a patient's diagnostic odyssey, when they've actually run out of options. So in a project that was conducted by the Primary Immunodeficiencies Genetics Research Group at Tygerberg Hospital, we recruited a total of 80 patients. We had more patients, but we were only able to have 80 patients sequenced with suspected inborn errors of immunity. And we had an additional 107 family members of these patients who were included. The majority of these patients were recruited from Tygerberg Hospital, from the Western Cape. There were a few who were included from private settings and those that were part of collaborative studies, but the majority of these patients came from the immunology clinic at Tygerberg Hospital. So whole exome sequencing was our go-to approach for 54 of these patients. We focused specifically on patients between the ages of birth and 15 years who had severe, persistent, unusual, and recurrent TB. And as far as we were able to, we recruited family members. So we had trios and duos that were sequenced, and we looked at that 1% of the human genome. Running concurrently to this, we had data that was of samples that could be sequenced, at Invitae. So these samples were outsourced to through a collaboration with the Jeffrey Modell Foundation, and patients were assessed at the same clinic. And if deemed necessary, these patients were sent for panel screening. This means that either 206 gene or 407 gene at the end of a panel was selected for sequencing for possible diagnosis of an inborn error of immunity. So both of these next generation sequencing platforms yielded good results, where we had 31% of our patients with definitive molecular results. But in the same breath, we had only 12 out of our 26 patients who were sent for panel testing, so 46% of them, who came back with an actual result. And we had 12 of our patients with a definitive whole exome sequencing result. And then we had 25% of these patients with no variants of interest, and about 44% of them who had variants of unknown significance. So variants of unknown significance are quite interesting in that there is no experimental evidence to support that they may cause disease, but in the same breath, there isn't sufficient evidence to prove that they may not cause disease. So these will need to be examined further in a research setting. So the question then came up, well, is whole genome sequencing feasible? If we've now tried the targeted panel and we've tried the whole exome sequencing, is it feasible in the context of inborn errors of immunity in South Africa? So if we consider the fact that, if we just go back one slide and we consider the fact that only 23 of our patients had actual results from whole exome sequencing and 31% of our patients had definitive molecular results, we'd essentially hope to push that up much higher. And through a collaboration with the Francis Crick Institute, the Crick African Network has allowed the whole genome sequencing as a pilot study to be run to see whether or not it is feasible in the South African context. So this project focused specifically on pediatric tuberculosis. Now we know that children who are younger than 5 years have a higher risk of disease progression following infection. Children who are between birth and 2 years are the greatest, are at the highest risk of developing active disease post-infection. And the hypotheses behind this is the fact that the adaptive immune response is ineffective and may lead to disseminated disease, or that there are specific antigen-specific Th1 responses that don't function properly. But as we can see, the risk falls significantly in primary school years, and these are considered the wonder years or the golden age. So the question is, why do these patients not develop TB as they sort of fall between the ages of 5 and 10 or 15? So we know that MSMD, I know it will be well characterized here, is essentially the predisposition to infection with weakly virulent pathogenic mycobacteria. And in the South African context, it is something which we need to look at, simply because many patients with suspected MSMD in the absence of HIV may also present with common old garden TB, as the clinicians refer to it, rather than the environmental or non-tuberculous mycobacteria. So we don't know what the actual prevalence is, and we all know this is as a result of the massive HIV and TB epidemic. So, you know, it's very seldom and very often these patients die before they're actually suspected of having an MSMD, because we just think it's part of the disease burden. So understanding why only a subset of these children, as previously discussed, develop active TB post-infection remains unresolved. So we know that there are specific cell types which play a role in the immunity at specific times. Is it the bug possibly, or is it the genetic makeup of the patient as a whole? So for this study, in collaboration with the Francis Crick Institute, the hypothesis is that children with severe, persistent, unusual, and recurrent episodes of TB have genetic variants which will predispose them to disease, and we aim to find them using whole genome sequencing, and then obviously characterize these variants, because not all variants will be associated with disease. So the materials and methods were, we had patient recruitment at Tygerberg Hospital, and we had whole genome sequencing, which every whole genome sequence, we would then have to validate each positive variant And if we had a negative result, we would then use another next generation sequencing technique, RNA sequencing, which we won't go into today. But the point is, the idea is then to identify the possible pathogenic mutation. We sent 70 samples, this was pre-COVID, for whole genome sequencing. And we got very good data from the whole genome sequencing, which is all we need to know is important. And we know that for the MSMD, we know that, the predominant pathway is the IL-12 interferon gamma pathway. And the preliminary investigations of these specific patients sent for whole genome sequencing looked at the IL-12 interferon gamma pathway. And no significant variants were identified in any of the 15 genes that had previously been associated with MSMD. So we knew we were looking for something else. However, what is interesting is using whole genome sequencing, we found that a total of 21 of these patients carried variants in a gene called TBX21. And TBX21, in a paper that came out last year in 2020, has been associated recently with immunity against mycobacterium. So variants in this gene are likely to underlie mycobacterial disease by preventing the development of interferon gamma production by innate NK cells and innate adaptive lymphocytes. So what's interesting is, or what is the question is, would we be able to use TBX21, the protein expressed by TBET, would we be able to use it as a proxy marker for SPIRT TB? In other words, because it's induced by T cells through STAT1 and STAT4, both of which are central to the IL-12 interferon gamma pathways, if you have disruption in TBX21 and subsequently TBET, is there the possibility that this can be used to pick up these patients who have then got defective immunity against MSMD? So once TBET is induced, you've got a whole cascade events of activation, trafficking, and immune regulation. And then the idea would be then to look at it and to see, well, what does TBET look like? How does it play a role? And would we be able to look at what these specific variants, so note that all of these patients had variants in TBX21, but not all of them had the same mutation. So we know it's likely to be something significant. So we would then, using immune cell function, we would then have a look at how these variants then impact the functioning and whether or not the IL-12 interferon gamma pathway is affected. So in short, we've taken whole exome sequencing, which didn't quite yield very good results, and we've managed to then identify novel mutations in TBX21, which are likely to be then translated to scientific evidence to prove that these variants may act as proxy markers for MSMD. So whole genome sequencing in 2018, in November of 2018, let's say July of 2019, became a reality in South Africa. So we, through the SAMRC's Genomic Center, we were able to start the Genomic Center, and we were able to initiate the first human whole genome sequencing on the African continent. At that stage, it was the first whole genome sequencing we knew of on the African continent for humans specifically. Now, what this means is that African researchers as a whole no longer need to send samples overseas to collaborators. All work is done locally, which means we don't need export permits or import permits anymore in some cases for samples. We know where the data is stored and where it's kept. We know that we can pay in rands and not in dollars or in pounds, which really significantly increases the number of samples that we can look at. And we know that in the South African context, all the work stays South African. It stays here and it stays South African property, including the data. And we know that for the first time, this significant sequencing technique is done on African soil. So in short, we know that next-gen sequencing has become the mainstay for inborn errors of immunity in clinical settings. And we know that in developing countries such as South Africa, we've got significant problems. We've got low sample numbers, and very often patients die before we can actually do anything about the identification of their variants, or they come to us too late. We know that the costing is a problem. Not everybody can afford what it costs to send samples overseas. We know that data interpretation is difficult. It's not easy to identify variants with 3 billion nucleotides that could possibly be different. The African continent has extremely unique populations, and unfortunately, all of the references that we use to identify mutations are used. We have to compare them to a European reference genome. The more data we generate here, the more likely it is we can generate a African-specific reference genome. We also know that from a clinical perspective, and given the high infectious disease burden, there is a huge lack of awareness, number one, to inborn errors of immunity, and number two, to the facilities that are available to help diagnose specific patients. However, the availability of whole genome sequencing in South Africa allows for us to try and combat some of these challenges. And I would like to thank the following people. There are a lot of them, if we go back to this slide, and without which this work would not be possible at all.
Okay, thank you. I would like to thank all colleagues for this excellent presentation we had this morning. So this was a very inspiring session. I think that as a start for this Congress wouldn't be better. Discussing the management of PIDs, and particularly in our settings in Africa. I think that we had a very interesting introductive talk by Shereen, who did talk to us about the scheme, or developing a scheme. I would like to thank all colleagues to facilitate the diagnosis of these patients, both at the clinical point of view and from the immunological point of view. Then we had discussing the management of PID.
Il faut fermer YouTube.
Oui, c'est ça. Okay, so I will continue. Sorry, there was some background. So Shereen did present the scheme to develop a diagnosis of these patients, of these PIDs in our context in Africa, both from clinical and immunological point of view. Then we had a talk by Nermeen, Dr. Nermeen Galal, who did an excellent talk about the diagnosis of early in age of these patients, and that's what we need. We need in Africa to be aware of these diseases as early as possible, because the management will depend on how much we discover these diseases early, and this is extremely important. Then Brahim did talk about the importance of the phenotyping and immunophenotyping using the flow cytometry technique, as you understood, and I think that the immunological diagnosis and the immunological phenotyping will still be extremely important to diagnose and to manage these patients. And even if genetic is coming, we know, but the phenotypic diagnosis is still very important, extremely important. And I think it is solving many of the cases before going to genetics. At the end of this session, we had the excellent talk by Brigitte, who did introduce us the data from South Africa about the genetic diagnosis of these PIDs and how much it could be useful. And we will certainly, during the discussion, come back to these aspects. I'm personally pretty much interested in this. So the first question that we had in the chat is from Randa Salah Osman, and it is to Shereen. And she was discussing the possibility to further highlight what we can do to prenatal and neonatal diagnosis, but this could be discussed by Shereen or any of our colleagues who talked, of course. So this is the first question. Would you please highlight more prenatal and neonatal diagnosis opportunities? Please, the floor to the speakers.
So can I share my opinion here? Very important, of course, to have the neonatal screening or the prenatal diagnosis. This will help a lot to identify patients who usually are not diagnosed and they pass unnoticed until death, especially in the severe forms of immune deficiency like the SCID or the XLA. You have to get the prenatal diagnosis. Very important, of course, to have the neonatal screening or the prenatal diagnosis. This very important, but so far we don't have the facilities, and we encourage the African continent all the countries in the African continent to stress on the value of the neonatal screening. This is very important, but so far we don't have it in many of the African continent, including Egypt, here in my country. And we look forward to have this neonatal screening anywhere.
Yes, I agree, Shereen. I think that the neonatal screening is extremely important. We are lagging behind in terms of having this opportunity in our country. Same situation in Tunisia. We did not start that, but what we did start is neonatal diagnosis, which could be performed when we have a minimal, of course, information about the genetics of these of disease in these patients, and that's why I think that
you have an individual case. If you have one patient, then you look for the other siblings.
Exactly. Yeah.
If I may add a comment, actually, to establish a prenatal diagnosis, you need to have the molecular defect, as you've kindly reported. So at our center, we've started doing this actually, but again, this will only highlight that we need more diagnosis or more molecular identification so that we can offer more prenatal services. So for you to think of prenatal diagnosis in particular, apart from newborn screening, you need to have the exact molecular defect so that you can perform the prenatal diagnosis.
Right.
Yes, I agree. And this is the way we are doing it here. We are focusing on families where the genetic defect has been identified. And so we are now proposing prenatal diagnosis in those families. And that could be done because we have, and particularly in northern part of the continent, we have strong founder effects for some mutation, which are very prevalent for some diseases like MHC class 2 deficiency, where only one mutation is accounting for almost 90–95% of the patients. So we can offer really easily this prenatal diagnosis and this genetic counseling, at least in the families. So I think this is a very important question, and it's a perspective, and it is stressing the importance of starting to do molecular diagnosis in these patients. This will be extremely critical for the future of the diagnosis of these patients and the management of these families in our continent. So this was the first question. Are there any other comments by the speakers? Okay. If not, I will move to the second question, which is to Shereen Reda as well. It is by Mami Tenin Diai, who is very active. She has been asking for several questions now. And the question is it possible to suspect a PID only by immune disease in child, autoimmune disease in child, for example, lupus in a child without clinical infections? So,
well, this is a very important question, and the answer is very challenging because sometimes we have primary immune deficiency diagnosed first as PID or IEI, and then the patient develops autoimmune manifestations. This is the easy way, but the difficult way is that you get the first presentation with autoimmune manifestations, like any other autoimmune thrombocytopenia or autoimmune hemolytic anemia or autoimmune neutropenia, anything of these, or you get the patient with vasculitis. What is the importance here is that you look at the age. If you have a patient in young age presenting with one or more of these symptoms, and you suspect primary immune deficiency. But let me tell you honestly that these patients usually are referred to the hematology unit. And by chance, they look at the possibility of IEI. But for the autoimmune to present as brand new or the first presentation with autoimmune manifestations or with immune dysregulation, you have these patients to be diagnosed specifically based on the advanced molecular and the genetic testing. And that's why the IUIS, they usually, every 2 years, they have new genes discovered. If we go back maybe 1 or 2 decades ago and you look at the IUIS classification, you won't find the autoinflammatory or autoimmune diseases there. But thanks now with the advances in the molecular and genetic diagnosis, they can identify them. We have many patients actually who were diagnosed first with autoimmune manifestations. For the question here is about SLE. Well, SLE, the classical presentation usually is not in the early years of life, and usually they have the 4 out of the 11 criteria for the diagnosis of SLE. If you have a patient with 1 or 2 of these symptoms or manifestations, and if you have a family history with autoimmune diseases, then it is high likely to be an autoimmune underlying immune deficiency. But the only diagnosis here is by the advanced molecular and genetic testing. It's very difficult to have it unless you have the syndromic, like the IPICs, for example. Then you think of the IPICs. If you have the polyendocrinopathy, the enteropathy, the immune deficiency in a boy, this is a case of IPICs. But otherwise, it's very difficult to pinpoint the diagnosis of IAI in autoinflammatory conditions without having molecular genetics.
Okay, thank you so much, Dr. Reda, for this. This is really the situation for all of us. We have difficulties sometimes. That's correct, and I think that what we could suggest is when you see autoimmunity against the blood cells, I mean anemic autoimmune hemolytic anemia, or neutropenia, or autoimmune neutropenia, or autoimmune platelet affected. This should help us think about immunodeficiencies, because very often we see these features, these biological features, and sometimes they have clinical consequences, and sometimes they are like in different situations. You would agree, it could help in that area. But the other thing where we have been misled sometimes in terms of diagnosis is autoinflammatory, as you said, diseases, where we had colitis, which were really misleading the clinicians, and no one thought about immunodeficiency in those patients. And this is also another example where, yes, we can, through some clinical features, suspect, and biological features suspect some PIDs behind autoimmunity, but it's difficult in the first, particularly in early age. Any other comments about this by other colleagues? Aziz? Is okay, maybe he's not listening to us. Okay. If no further comments by the colleagues, I will go to the third question, which is about the chance, the percentage of chance, or the chance to have neonatal erythroderma being a
No problem. I agree. When it is syndromic.
I will go to the third question, which is about the chance, the percentage of chance, or the chance to have neonatal erythroderma being a
No problem. I agree. When it is syndromic.
Please go ahead, Aziz. Go ahead with your comment, please. I will come back to the third question. Hello? Hello, Aziz? I think there's some trouble with the connection. Do you hear me? Okay, Omar, do you hear me? Okay, so Aziz is not connected from what I understood. Okay, so I will move to the third question, which is by Dr. Ndiaye as well. So what is the percentage of chance that neonatal erythroderma is Netherton syndrome? And the question is, I think, to Nermeen, if I'm not.
Okay.
Yeah.
Well, it's an excellent question about puzzling a neonatal or a clinical situation, neonates where you get a newborn with erythroderma. I do not have an exact number for the chance, sure. But again, the most important thing is to identify it, because there are a lot of causes that may cause this presentation, neonates, like even staph infections. You can get it, with atopic dermatitis, some cases like the Omen syndrome we've seen in the slides, or some conditions like GVHD. So the important thing is to just think of those disorders till you get more clinical details to point you in the right direction. Again, with Netherton, you do not get a frank presentation. The hair is not usually sparse and abnormal at birth. They tend to develop the manifestations with age. So it would be really hard to pin the diagnosis. But again, you would need to resort to a clinical suspicion and then narrowing, or I would say more of exclusion of the other causes till you get a molecular identification of the problem.
Yes, sure.
Short answer is I don't have a number.
No. There's no percentage to give, for sure. That's exactly. For sure. But she was, I think, suggesting that is it very frequent or not. So
I would say the other causes are more common, like the psoriasis and atopic dermatitis and the medication reactions and the staph infections, and the rest of the other causes may be on top of the list rather than the less common disorders.
Yeah, right. Yeah, absolutely. Okay, thank you. Thank you for this answer. So let's move to the fourth question, which is to Dr. Brahim Belaid. So she's asking about the role of flowcytometry in the diagnosis of hyper-IgE syndrome patients. Hello, Brahim.
You hear me, Professor?
Yes, we hear you. Yes, please go ahead.
Thank you for this interesting question. Yes, there are several tests that we can use by flow cytometry, but this is just for screening, because the definitive diagnosis remains the genetic study. But so with the flow cytometry, yes, we can test or assess the phosphorylation of STAT3, but you have just to be careful, because not all mutation can give a phosphorylation defect of STAT3. So in defect of STAT3, we can also assess the expression of the two subunits of EL6 receptor, namely EL6ST, EL6RA. We can also verify the expression of DOC8 recently. The new test has have been also, it is possible, is available. I think that by flow cytometry we can use only these tests, 3-4 tests in hyper IgE syndrome.
Yes, thank you, Brahim. May I just add maybe that if available, one could also do some STAT3 phosphorylation studies, which could help, but are not absolutely definitive for importance for the diagnosis itself, but could help. So phosphorylation of STAT3, we are screening sometimes that way to identify some of the patients, but not all patients with hyper IgE have a defect of STAT3 phosphorylation, of course. So it's just an additional tool. Okay, would you agree on that? Okay, thank you, Brahim. So let's move to the remaining questions, which are most of them about the genetic part. So thank you very much, Brigitte, for your talk. And the first question is about, do we need first an immunological investigation before going to genome sequencing? This is one of the questions.
Yeah, so thank you very much. So I think what's important is that the immunology and the genetics cannot be viewed independently of one another. So, and I think that's important is we need the immunology to understand the genetics, but in the same breath, we need the genetics to try and understand the immunology. So we always have routine immunological screenings that get done in our patients. And then based on the genetics and our findings from the genetics, we then determine whether or not the variants of interest are actually ones we should look at further. Sometimes it's easy and it's variants that have been identified before, but in a lot of cases, there'll be new variants that haven't yet been identified or associated with a specific IEI in question. So yeah, I don't think you can view them as two separate entities.
Yes. Yes, this is an interesting question indeed, because we are in a crossroad period now in terms of what to develop in countries like Africa, in African countries. Is it more appropriate to go quicker to the molecular tools, which are maybe very expensive for some of our countries, but are becoming available, fortunately, or to invest more in much more functional studies, much more immunological phenotyping? In my opinion, we will still need always immunological phenotyping and screening first. That will be needed in any case. But how much fast we switch to the genetic and we move to the genetics, that's the question really. And depending on the settings where people are working, it's really it will be really an important question to discuss in the next coming years. Yeah, sure. See, the other question is about how long it took you to have the human capacity building to develop whole exome sequencing or generally the genetic tools in Africa, in South Africa.
Okay, so that's a tricky question. So we had the technology available, but the ability to interpret the data took a bit longer. So the primary immunodeficiencies genetics group was started in 2013. So it's been around for a long time, but we only started really getting success with the whole exome sequencing in about 2015, 2016, as our knowledge and understanding of the technology improved. So I think it's not a quick thing to do, and whole genome sequencing is even worse. With exome sequencing, we were lucky in that the technology was also available locally. So that made a big difference.
Yeah, may I just add that we need to keep in mind that we need to have bioinformaticians who are trained in our country. And that's the most difficult thing. And having data may be easy if you pay the price, but analyzing the data is another story. And that's why I think in Africa, there's some effort now to develop with the A.S.H., the SOMBI in South Africa and other institutions, including the Pasteur Institute in Tunis, to develop the bioinformatics capabilities of our institutes and and this is really crucial for us, because no one will analyze the data as good as you will do it, knowing what are the patients, what are you looking for, and so on. And this is really very important, because we had a similar experience than you did with the panel, and we had this similar result. third of the patients, we solved the problem. But for the two other thirds, we didn't. And that's really a real problem because we have many variants who are proposed, some are very suspected, and it's a real problem. So what I think is that the immunophenotyping will help solve the most of the patients. Genetics will help solve the problem for some of them, but probably not for all of them. It will take more effort maybe and more strategies. And here I have questions to you. What do you prefer between panel, starting with panel, or whole exome sequencing, like some people are doing now? What is your point of view about that?
Please, Brigitte, and Reda, we have only 1 minute for close the session. So please, your comment.
Can I give a quick answer?
Yes.
The quick answer is, in my experience, we've had equal success in the two. So I think if you've got a clinical phenotype that looks like it might be something, send it for a panel screen. If it's a clinical phenotype that's maybe a little bit more complex, then you do exome sequencing. That would be the short answer.
Okay, so we don't have more time. I'm sorry for those who just sent their questions. It's a little bit late for us. I'm sorry for that. So with this, I'm going to give the floor to Aziz to conclude the session, and I would like to thank the organizer for this outstanding session and the Congress in a very unprecedented time, as you know, and thank you for your efforts. Hello, Aziz.
Oui, merci Reda, shukran Reda, thank you very much Reda, and to all the speakers. We had an excellent beginning of our Congress. Thank you Nahla and the team, the Board of African Society. I want to thank particularly the speakers with their excellent talk and the pretty slides. So now we must end this session, and don't go away. The Congress continue. You are always and you are welcome. So we'll continue the next session according to the program. Thank you for all of you, and merci beaucoup. Shukran.
Good afternoon, everyone. I would like to start the next session and introduce a very close friend of mine, Patricia Karani, and she's going to talk about her journey with PID living in Africa as a patient. She's a regional patient advocate for Hereditary Angioedema International, and she's in charge of the Sub-Saharan region. She raises awareness amongst patients and clinicians, working with clinicians to raise awareness in Africa. She's a powerhouse of force in the area and in raising awareness, and we have huge respect for her. She's a patient suffering with HAE and tells her story and brings you to tears. So enjoy the talk.
Hello, everybody. My name is Patricia Karani. I am a patient living with a primary immunodeficiency in Kenya. And I would like to share my story on how I have heard my journey with a condition called hereditary angioedema. First of all, I would like to thank the 7th Congress for ASID for inviting me to be part and parcel of this great conference. And I hope you will enjoy my journey living with a rare condition in Africa. So I am the regional patient advocate for an organization called HAEI, which stands for Hereditary Angioedema International. And I take care of the Sub-Saharan African regional patients, as well as bringing together healthcare professionals and raising awareness in the region. I am also the founder and CEO of Hereditary Angioedema Kenya Foundation. So hereditary angioedema is a severe and life-threatening genetic condition that is caused by deficiencies in a protein called C1 esterase inhibitor. It manifests itself in massive and debilitating swellings, which normally are misconstrued for allergic angioedema. Therefore, there is a very high possibility of misdiagnosis and for the condition to actually be missed by healthcare professionals. There are different types of hereditary angioedema, and me, I am a patient who has hereditary angioedema type 1. So there is a gap in Africa in terms of how many patients are available. When we go by the prevalence rate, that of course has come from a lot of research that has been done in the Western countries, we find that the prevalence is 1:30,000 to 1:50,000. So in Africa, where we have about a population of 1.3 billion, and the probability being about 43,000, we wonder where the gap lies, because so far we've been able to find out about less than 150 patients in the region. Some in Sudan, 2 in Senegal, 4 in Kenya, and 100 in South Africa. So where are these patients, you would ask? Are they in our hospitals? Are they in our private clinics? Are they at home, having been ostracized by society due to the way the swellings manifest in a way that it is not understandable? Are they misdiagnosed? Are they underdiagnosed? Has there been a failure to recognize that allergy medicines do not work for this condition? Or due to the high mortality rate of 30%, have these patients died? So my journey to diagnosis has been a long and enduring one because I was first misdiagnosed with duodenitis. I've been misdiagnosed with typhoid. I've been misdiagnosed with ulcers. My father was told that he has a fish allergy. My brother was told he had food poisoning. So amongst all that, there has been a diagnosis of allergy. So I actually have allergy to dust and mold and also cold weather. So that was a diagnosis, a proper diagnosis that was done on me. However, it did not explain the angioedema swellings in totality. I've also been diagnosed with a bacterial infection, that's the H. pylori, which was a trigger for my hereditary angioedema abdominal swellings. So my first attack happened when I was 8 years old. I was hit by the edge of a window on my forehead, and I got a swelling that was more than a normal bump. And back then, nothing much was thought about it, so it was not a big issue for concern. So as time lapsed, 18 years later, I finally got diagnosed by a doctor who looked at me and said, I know what this is. This is angioneurotic edema, which was what HAE was called back then. And this happened 10 years later after my first HAE attack when I was 8 years old. This is a condition that runs in my family. So we are 6 children and 3 of us have similar symptoms and diagnosis. That is 2 brothers, and I am the only girl that got this condition. This condition was inherited from my father, who in turn inherited it from my grandmother. From my past research, my grandmother died from a neck swelling that choked her to death after she had come from the farm and she was not feeling too well. So she died within hours. So out of desperation, another 10 years later, I had to turn to Dr. Google because life had become unbearable. And I needed to know what this condition is and how I can find a solution or some relief living with this condition. And I finally found out that it's called hereditary angioedema. So these are some of the manifestations on my body. So I get hand and foot swells, as well as something which I came to later realize called the abdominal swellings, which are actually very painful, debilitating, and they are accompanied with nausea and diarrhea. So I'll take you through like an episode of swelling that I had. And the trigger for this swelling was an acne that was actually on my chin. And because the acne was a little bit itchy, I itched the acne. This was during my menstrual cycle. And it triggered the HAE, as you can see on the photo shown there. In the same day, it was a rapid swelling. And in less than 5 hours from onset of this swelling, this is how my appearance looked like. So in the same day, in less than 7 hours, I could not see, I could not swallow, and I could not breathe properly, as you can see from the photo. It was not just swelling externally, it was also swelling internally. So with a fully blown face, on day 3, from the onset of my swelling, this is what I looked like when the swelling had already started subsiding. And on day 7, this is my normal face with no swelling at all. There's no evidence of trauma. There's no evidence of swelling. So these are actually 7 days where I missed work or 7 days where I missed school. And these are 7 days in a month of not being able to do anything, as this condition is very debilitating and one is not able to actually do anything once the swelling has started. So my experience in the ER has been quite a challenge. This is, I think, basically due to the fact that rare diseases are not part of the training curriculum for medical personnel in medical school. So there was an inability to clinically identify this condition, to diagnose it, and even to manage it. So even after I got diagnosed, I was still not put on the proper medications to manage my condition. So it continued being severe and actually unbearable. There was also a lack of clinical guidelines on how to manage this condition. So administration of corticosteroids does not actually resolve HAE swellings, and this is what I had been put on. Fresh frozen plasma was not recognized as a treatment for an acute attack. Danazol and all these 17 alpha alkylated androgens were actually not recognized as prophylactic treatment to prevent me from swelling. And of course, there was a lack of the non-steroidal HAE medicines, such as the the C1 inhibitors and the icatibant injections, which are actually not available in the hospitals in my country. So due to this, the fact that I was not getting any result from the hospitals, I actually stopped going to hospitals. So you wonder, how did I survive? So I tried, when I was not swollen, I tried to go to the private clinics and explain my case and try and get a resolve or a way to manage my condition. But this is what I met. I was told, I don't want any legal issues. This was basically by a healthcare professional who probably felt that they're not able to manage my condition due to lack of knowledge. I was told that I am a walking time bomb. I was told that I need to go and Google and come back for another appointment. I was told it is just normal allergies. It will get better with time. So from both the public hospitals and the private hospitals, I was not able to get any resolve for this condition. So how did I survive? First of all, going to hospital became too expensive, because even though I went to hospital, the swelling never, it still went to being fully blown swelling, and me struggling to breathe, and me struggling to swallow saliva, and me choking. So I chose to stay at home because I saw that it was really eating into my family finances. My angioedema attacks, especially when I reached teenage, the age where hormones are raging, and hormone being a trigger for HAE, became more frequent. So every other month I was going to hospital. So I actually chose to stop going to hospital because even though I went to hospital, I was still swelling for 5 to 6 to 7 days, and there was really no resolve for these debilitating swelling. So this left me very traumatized. And the swellings that used to traumatize me the most were the throat swellings that threatened my existence, and the intestinal swellings or the abdominal swellings that were excruciatingly painful, and at times found me passing out more times than I can count. So I would hide in my room, I would sit down and pray and try to keep alive, to try and keep my airway open. So I would sit at a 90 degrees against my bed and just sit and wait. So I was ready, and I knew that anytime I could die or I could live. It was a 50-50, and I was never, I was always ready for any outcome. Because I was not put on any proper medication, I chose to overdose on steroids and antihistamines. I remember I would use a whole bottle of antihistamines, and I would buy a whole bottle of celestamine, and I would do 1 celestamine and 2 peritons at the same time every 2 hours, especially when it was a throat swelling. And that brought a lot of conflict within myself, because I knew that if this swelling doesn't get me, then probably the overdose of these medications would cause me problems. So it was very difficult to handle these severe attacks. So why am I here today? Why am I advocating for my condition, and why is it that I am able to share my story? It is because I finally got to know the value and the importance of patient support groups, locally and internationally. And I got to know that I'm not alone. That empowered me and gave me hope that I would be able to share with other people out there about my condition and not get criticized and not get judged and not get ostracized. So I also realized that there is modern and effective medication that can stop these swellings in a matter of minutes. So I imagined my 7 days of torture would actually be reduced to just a few minutes. That gave me so much hope. And I also realized again that there is actually availability of prophylactic medications in my country. So this gave me the will to live. It gave me hope. So I grew strong, and I resolved that this is a condition that I can not only just fight for myself, but I can fight for others, because this is a manageable condition, and it is actually life-threatening if not well managed and treated. So I started the HAE Kenya Foundation, and I learned to start sharing with people so as to empower and help them. So a patient group, to me, provides a source of comfort for patients, so that one doesn't feel like they're alone, that they are able to share with no shame. It also alleviates depression, because at times I would be very depressed, and when you know that you can either live or die, that depresses and traumatizes you. So it gives you the will to live and to fight, both mentally and emotionally. It also helps you raise your voice, to help in raising awareness, so that no other person really needs to go through lack of proper management of this condition. And it provides a continuous learning environment about this condition, so that one is up to date with what is going on. These patient groups are also important to help in lobbying governments to change their policies towards rare diseases and to make rare diseases inclusive in their reimbursement schemes. So why do we collaborate with healthcare professionals? I have made it my passion to be able to speak with healthcare professionals, not just in Kenya, but in the sub-Saharan Africa, because I believe that every patient seeks help from a healthcare professional. And this being a debilitating condition and also a life-threatening condition, there is no need for any patient to die out of a condition that could, out of something that could have been prevented or better managed. And then this condition not only affects me medically, it affects my whole entire system of life. I found myself unable to socialize. Why? Because every other time I wanted to go out for hiking or to go out and meet my friends, I was swollen somewhere, and this prevented me from fully participating and enjoying all these social gatherings. This again, when it went to my work life, I was unable to be productive because every Monday I was unwell. And they would wonder, why is it that every Monday Patricia is unwell? And stress and anxiety being a trigger for this condition made my work life a bit difficult. My school performance was also affected because every time there were exams coming nearby, the pressure and the stress of the exams would make me have these swelling attacks, which I told you last about 7 days. So those are 7 days of either missing exams or 7 days of not being able to, to revise for my exams. So this affected my school life. So all this comes together and it affects you economically as a woman, as a young woman trying to survive in a society where you have to contribute economically. All this relates and comes to it comes to affect your mental health, whereby you're left with trauma, you're left with a lot of fear. You don't know when you're gonna get sick because it's very spontaneous. At times there's a cause for my swelling, and at times there's no cause. It's just spontaneous and you don't know what to pin it on. So that affected me mentally as well. So this affects somebody's life holistically. And this is somebody who relies on the healthcare and the medical system in a country to keep them whole, to keep them well, to keep them healthy. So this is the main reason why it's important for us to have these discussions with healthcare professionals, because this is not a condition that just affects me, physically. It affects my whole entire being of life. So there is actually a need and a sense for urgency, because this is a childhood disease. It started when I was a young person. It's a genetic condition, so it can be detected. It has a 30% mortality rate for undiagnosed patients. It is a debilitating and disabling condition. And patients with this condition are really, really trying to live a normal life. So to all the healthcare professionals, I would want to just give you one message. You are the last best hope for these patients. You are the people who are there on the ground to assist us to help realize a normal life. With these few remarks, I would like to say thank you very much. I hope you have enjoyed my presentation. Thank you.
Thank you, Patricia. That was fantastic. It is now my great pleasure to introduce Professor Jonny Peter, who is a physician who specializes in allergology in South Africa at the University of Cape Town. And he heads the Division of Allergology and Clinical Immunology at the Groote Hospital of the University of Cape Town and the Allergy and Immunology Unit at UCT Institute. And he, again, specializes in urticaria, angioedema, primary immunodeficiencies, and immune-mediated adverse drug reactions. And today he's going to talk to us about the strategies to bring targeted therapy for HAE to our patients in Africa. Thank you, Jonny.
Good afternoon. Firstly, to say thank you very much to the ASID 2021 organizers for inviting us to have this session and increase our awareness across the continent about this condition, hereditary angioedema. And today, following on really from what is a very moving story from Patricia about her patient experience that really highlighted many of the aspects of dealing with this condition in South Africa and also in the continent. What I wanted to talk to you about today is really some of the strategies that we've been using in South Africa to try and bring the therapy of HAE patients into level with international standards and access to targeting therapies. So firstly, I think that the key about this condition across the continent for doctors and patients is about awareness. And awareness here starts with diagnosing and knowing what we're dealing with. So really what we're talking about is angioedema. And angioedema is a sudden pronounced swelling of the lower dermis and subcutaneous or mucosal membranes. And you can see here can affect various parts of the body, quite commonly face, lips, tongue, also limbs, and even genitalia. They're really, from a diagnostic point of view in allergy, we think about angioedema in two contexts. And this, we think about it from a mechanistic point of view of what's actually the vasoactive molecule that's driving the angioedema. And we divide it broadly into two groups, bradykinin-induced angioedema and histamine-induced angioedema. And here I've listed out the different types. And from a clinical perspective, really one of the main things we talk about here is when angioedema occurs without any kind of urticaria or hives, we really do think and must think about bradykinin-induced angioedema. And by far on our continent and globally, the most common reason for that will still be drug-induced, particularly ACE inhibitors, and I've highlighted that here. And then what we're going to talk about are some of the genetic or primary hereditary forms of angioedema. Again, from a diagnostic point of view, the key is to identify red flags when this is not angioedema, and also when this is likely to be hereditary forms of angioedema, and what are the clues that kind of highlight to that. And we've actually put this together in a recent review article about mimics of angioedema. And here I've highlighted a few red flags on the one side, and I'm happy to share this publication widely with anybody that's interested. The key things here about three, and I've put here 3 pictures of things that look like angioedema that actually aren't angioedema. And the first key clues in these cases are in fact the location and the duration of these swellings. So angioedema is intermittent and is transient. And so in all of these situations, these swellings of here in this case, the eyelid and the lip last longer than 72 hours. Usually they're also at different anatomical sites. And these two things, the fact that they are the same site here in one site only, and the fact that they are prolonged should alert one to the fact that these are potentially not angioedema. Important aspects in both these instances are that imaging can be helpful. In the middle case, simply an ultrasound will identify this nasopalatine cyst. And then the other thing that's very important is a skin biopsy. So if there's a lack of clarity from a diagnostic point of view, trying to organize a skin biopsy can be very helpful and very important for the management of patients. From our hereditary forms, like in other of the primary immunodeficiency, where we use family history as a key component, the major form of hereditary angioedema, which is known as HAE-C1 inhibitor and relates to antigenic and functional defects in C1 inhibitor, are autosomal dominant in inheritance. And what this means is that from a family history, the majority of instances you will find cases across different genders and in multiple generations, and each generation, like in this family tree that I've shown. The important thing, though, is that as a field, hereditary angioedemas are going far beyond now this type 1 hereditary angioedema with gene defects in just the SERPING gene. And they've now had families identified with problems in a number of these molecules within the kallikrein-kinin system, as well as some other endothelial molecules. And so I think that the key thing here is to, when you see somebody with primary angioedema, ask about a family history. Are there any other members of your family that have a similar condition and is this, and it can vary as well, importantly, in severity. So one individual may have frequent attacks, one person may have only had one attack in their entire life. And I think that's important to note. The other thing, of course, is I showed you in that very second slide that drug causes are the commonest presenting problem for angioedema. And we did a recent audit across 2 hospital emergency units, and at these ER facilities. And of those, about 25% were related to ACE inhibitors alone, and a further 10% around to non-steroidal drugs. So these are the other 2 questions when you see a case of angioedema. Importantly as well, for these cases, history is absolutely everything, because at the moment there remains no good biomarkers for drug-induced angioedema. We are currently embarking on a project with the MRC to try and identify this biomarkers and also genomic biomarkers for this form of drug-induced angioedema in African communities. So getting a little bit more detailed into hereditary angioedema. So I've told you already that it's an autosomal dominant condition. I've mentioned the SERPING1 gene, which codes for the C1 inhibitor, C1 esterase inhibitor. The prevalence is estimated to be about 1 in 50,000. And this is probably true. Our Western Cape data says it's around 1 in 140,000. And it gives you this recurrent episodes of non-itchy, painful angioedema without urticaria. And there's been several mutations across this gene that all lead to the similar presentation. And there again, I've mentioned the duration and the fact that traditional methods of treating histamine-driven angioedema are ineffective. So that's another thing that often happens. Patients or doctors will be treated with a particular kind of therapy for their angioedema without response. And yet every time, and we still have this in our setting, patients are accessing emergency services and yet again and again receiving the same treatments. If you look at this disease across a lifetime, and I think this is very important because what the new aim with the available treatments we have for patients with hereditary angioedema is a normal quality of life. And one of the things that's really challenging about this condition is that patients can have a reasonably normal quality of life and then suddenly have a life-threatening severe attack, and that can occur at any time. And it's the unpredictability of this that actually creates a lot of significant anxiety, depression, and fear. And the important things that the attacks can be triggered by dental procedures or other surgical procedures, even stress, hormonal changes, or just occur spontaneously out of the blue for no reason. And so getting patients controlled or empowered to look after the disease can be quite a challenge, given the sort of unpredictable nature of this disease. In terms of the pathophysiology, and this is relevant to our discussions a little bit around targeted therapies, is when you have a deficiency in C1, either a total amount or in terms of function, what happens is you lose inhibition of the natural activity of plasma kallikrein. And what that means is that with increased activation of kallikrein, you get conversion of high molecular weight kininogen into cleaved high molecular weight kininogen and bradykinin. And bradykinin is a nonopeptide that is very vasoactive and responsible for acting on the bradykinin 2 receptor, which is a G protein couple receptor, to lead to split opening of the endothelium and leakage of fluid into the interstitial space, and that gives rise to the edema. So that's the key pathophysiology and mechanisms. In terms of our current drug armamentarium, the key things that we may be familiar with, or some of you might be familiar with, is that we use attenuated androgens to increase C1 inhibitor protein levels, and that's a C1 inhibitor is produced by the liver. We also use tranexamic acid or E-aminocaproic acid, and these affect the activity of factor 12A. There's a lot of focus, and I'll show you some more about new developments in direct kallikrein inhibition. We then have plasma-derived and recombinant forms of C1. That's again a targeted therapy. And for most of us, I'm going to show some local data on the use of fresh frozen plasma when these products actually contain C1 inhibitor that can help patients. And then importantly as well are the bradykinin 2 receptor antagonists, which are downward here in the pathway where bradykinin acts on this receptor. If you look here, this is some of the more modern treatments, and I've mentioned kallikrein inhibition. Here you can see there's a monoclonal antibody called lanadelumab, which is FDA approved. They are now an oral kallikrein inhibitor called butralostat, which has also recently been approved, and we were part of the clinical evaluation of this, and I'll show you some slides down the line. Then there's also subcutaneous C1 inhibitors, and now factor 12 molecules in development. And also, in addition to this, there's a whole nother pipeline around gene engineering and a whole lot of other aspects. So really, like the kind of range of products targeting this disease is wide. And the key thing, therefore, is access, and how do our patients in South Africa get access. I think in that context, it's relevant to look at this timeline, which contrasts on the top global international developments in the field of HAE with South African developments. And you can see here that the condition was described all the way back in the 1880s, but it's not really until the last 2 decades that there's been a massive surge in the development of targeted therapies and what I've shown you here are icatibant, that's the bradykinin 2 receptor antagonist, Berinert, these are the plasma-derived C1, Ruconest is the recombinant C1, and here lanadelumab is the monoclonal against kallikrein. While that international development has been going on the bottom, I've put here some of the milestones in treatment in South Africa of HAE patients. And I think what's key here actually has been the patient advocacy groups. And so this here in 2004 is the formation of HAE International, which is the global patient organization. And here, the first HAE-I International patient meeting in South Africa in 2017. In 2009, the first publications about SAE were published. And my predecessor, Paul Potter, was very influential in getting clinical trials to help get access for his patients, and was part of the early development on icatibant, for which 2 patients are still accessing this therapy in a post-trial access format. In 2018, we published some local outcomes on our cohort. And in March 2019, we had our first patient meeting, and we joined the Global Access Program for Ruconest. So I think this sort of highlights the much more recent developments in our context against the context of international developments. In terms of the landscape until recently in South Africa, I've mentioned the kind of prevalence. I've also mentioned the fact that there's really a problem with diagnosis and a lack of awareness. We've got C4 complement testing readily available almost across the country through our public sector and private sector laboratories. And complement C4 for screening out type 1 and type 2 hereditary angioedema has a negative predictive value that's over 96%. And so therefore is a very, very good first screening test. So there's actually no need necessarily to do more complex measurement of antigenic C1 or even functional C1. C4 will give you a very good starting idea for the patient. In terms of management of our patients, the problem that we have is access to health facilities, limited public sector transport. And I'm going to show you in the next slide about our 2 deaths that we've had in our cohort, which really relate to this problem entirely. The difficulty is that fresh frozen plasma up to now has been the only treatment available for acute attacks. And then also very limited options for long-term prophylaxis with only attenuated androgens and antifibrinolytics. In terms of our cohort in the Western Cape, the majority of these patients are still using danazol, which is the attenuated androgen, as first-line prophylaxis. And I believe this is similar from my conversations with other doctors across the continent. This is a similar strategy and situation in other parts of Africa. In terms of our deaths in our own cohort, which is now about 80 to 100 patients that we manage in South Africa, we've had 2 deaths, and both deaths were related to laryngeal asphyxia. And the main issue here is that both lived far away from the hospital, and they really died as a result of delayed access to a high care medical facility. Because if you can access care early, emergency care early, and you can protect the airway, then patients, the angioedema will resolve, and this leads to survival. More recently, we had another death that really highlighted the complex social nature and area in which we care for these patients, where we had a convicted criminal who actually never continued or never was compliant with their androgen therapy. And we first diagnosed this patient in ICU, and then subsequently he demised later, probably because he started having accelerated angioedema attacks because of drug abuse. So that also highlights the complexities of the sort of social milieu in which these patients are cared for. One of the first strategies that we've taken in South Africa to try and improve access was really to try and connect with international networks around HAE to get kind of access to clinical trials, to get access to the latest ideas in management, to start to be part of international guidelines and advocate for our special needs on the continent. And so at the Lung Institute and our unit, we joined up and became both a UCare and an ACare center, which is linked to the European allergy community. And what it really does is it's linked us with particularly HAE International, and it's also allowed people to identify us as a place where we could be a center of excellence, and then doctors would reach out to us, patients will reach out to us. So it's really a tool to drive advocacy and connectedness for this patient population. The next thing we did was we thought it was really important to produce some local data. And we started off by thinking about fresh frozen plasma use, because although this treatment is widely used across several developing country settings, there has actually, if you look in the published literature, there's only been 1 or 2 publications before this, and very limited reported use. So what we did is, together with colleagues from Iran, who have a very similar kind of demographic population, we looked at the use of fresh frozen plasma in close to 100 acute attacks. What we noticed is that, firstly, there was no worsening of attacks. And so that's been something that's always been of concern, is that there might be actually an aggravation with the use of this therapy. Patients did have to wait quite a long time to access the therapy, so it's not straightforward or readily available. Patients took about a median of 4 hours to start having resolution. And this is in contrast to some of the targeted therapies where resolution can be within minutes, but usually peaks within an hour. Unlike the initial dosing of 20 mils per kilogram, we found that most of these patients would respond to 1 unit of FFP only. And the problem with this therapy is that because it took a long time, most of these patients, especially in our context in South Africa, required hospitalization. So they needed to go into the emergency room. They would often be admitted. And this therefore meant that in addition to the costs of the therapy, you actually got to add the costs of the admission and all the care related to that. In terms of transfusion reactions and side effects, well, you can see here there was about 5%, which is the expected rate of blood product transfusion reactions. We did have some cases of anaphylaxis. And so this is another drawback to this therapy that people need to be aware of in terms of looking after them. And also another motivation potentially for targeted therapies, which have a better safety profile. But one of the major breakthroughs of this work was actually the cost analysis that we did. And what we wanted to simply calculate was, if you have to have this therapy and be admitted and sleep over in the hospital, what is the total cost to the healthcare system for a 36-hour admission? And what we discovered when we added this all up was that it was close to $800 US. And with this data, and then also with the global access program around the costing of Ruconest, which is the recombinant C1 inhibitor, we actually could demonstrate to our public sector health funders and providers that there was equivalency. So if you could use a targeted therapy in the form of Ruconest, actually you could have a net sort of equivalence for patients in terms of the total cost to the health system. And it was on this basis that we actually got the Ruconest approved for our public sector patients. This just here is also the other targeted therapy, which is a Catabant, which I'm also going to show you about the early access program. Here just contrasts the two. So I've told you now about the fresh frozen plasma, and you can also use freeze-dried plasma, and we've done that with some success as well if you're unable to access the fresh forms. But you can see here really when you put it head to head with one of these targeted therapies. So a Catabant can be used subcutaneous. So I've got patients that are using this therapy at home. So particularly for health access issues, this is a really potential breakthrough and life-saving treatment, and the time to onset, you can see, is much improved. And this usually completely avoids the need for any kind of hospitalization or even admission. So I think when you put the the FFPs, although we are using it widely and it can be used safely, and our data is published around this to help practitioners across the continent using this therapy, I think there's undoubtedly no question that targeted therapies offer a huge improvement on both access to care, quality of life, and also efficacy for patients. So this is the first thing that I wanted to highlight that really has helped us, is this global access program that's been developed and initiated under the banner of the HAEI International Organization, which, just to highlight, is a huge patient organization, one of the most successful in primary immunodeficiency diseases. It now spans over 75 countries, and really it's been driven by the patient needs. And so, and through some amazing work by a leadership team in the United States that has been committed to trying to improve the quality of care and the quality of life for patients across the globe. And it's through this and their negotiations with have we had so far? Well, we've got 11 patients in private sectors accessing this therapy, and we've also got 12 patients within the state sector accessing this therapy. And so you can see here, this was the first targeted therapy approved in our public sector for patients for South Africa. And we have now been using this regularly for short-term prophylaxis for the treatment of acute attacks. So this has really been very successful. Of course, this is an IV therapy, so it still has the need for people to access care, although the company has been increasingly working towards the use of this therapy at home, in the home setting, but that does require a substantive amount of education, training for patients to administer IV therapies at home. One of the things that we really must not forget, and I would encourage other investigators across the continent to think about, is the access through clinical trials. So at the bottom here, I've put the FAST-2 trial, and this was a trial of one of the first trials of icatibant. And you can see here that we still have now 2 patients very successfully accessing this medication through post-trial purposes since 2008. So that's 12 years of therapy. So an amazing route for these 2 individual patients. And so for colleagues, I would really recommend thinking about this. If you have patients or a patient community that doesn't have too many patients, if you can help to get them onto a clinical trial, and because this is an uncommon disease, globally, big companies are looking for the opportunity to partner with sites to do clinical trials and help access and this is a form of way in which you can access trial medication. So we've also got, we were also part of the betrolestat phase 2B trial. And you can see here, we've now got 11 patients that have been accessing this oral plasma kallikrein inhibitor for long-term prophylaxis for more than 3 years. They've also just started a long-term further clinical trial, which will be for another 5 years. And then after that, a planned early access program. So you can see how for these 11 patients, and again, this is a rare disease. So for 11 patients, this is potentially a life-saving strategy for them, accessed at no cost to them through this clinical trial purposes. So definitely this is a route to think about. Recently, icatibant, which was a drug developed by Shire. Shire has been recently taken over or purchased and acquired by TAKEDA. And what's happened is that they have now moved, TAKEDA, who have a very good footprint in low middle income countries, have moved to try and register icatibant in South Africa. And what they have done is, in this process moving towards registration, they have set up an early access program. Now, the advantage of icatibant, unlike Ruconest, is icatibant is a subcutaneous therapy and therefore can be administered very easily at home. And like I mentioned, those 2 patients in FAST-2 accessing this therapy. And what they've set up is a process that uses our specialist center, the A-Care at the Lung Institute, where if you have a patient that in South Africa that might need therapy, or even other patients on the continent could potentially be referred to us. They need to go through their physician. They come to our center. We will assess them, confirm the diagnosis, make sure that the treatment is appropriate. And we then have, through a direct relationship with TAKEDA, we have in our pharmacy, we have icatibant in stock. We will ensure that the appropriate Section 21 named patient forms are completed, and then the patient can be dispensed therapy and access it in this way. So this will be how it will work in South Africa until probably September, October 2022. So this is 1 year away before icatibant is formally registered with the SAHPRA and can then just be prescribed by doctors. What's great about this is that we've really sort of thought about the roles and responsibilities of both the local physicians, our A-Care Center, as well as the relationship we have with industry and the relationship of the patients and the patient organizations. Another exciting development, and I mentioned, and this is sort of coming back full circle now to what we were talking about in the beginning around making the diagnosis. What we really wanting to do through our A-Care is grow this South African, or even I call it an African angioedema hotline. And this is something that I was inspired to do by the French group. Now, France has a population quite similar to South Africa in size, and French allergists there set up a angioedema hotline around 10 years ago. And they've gone from receiving about 1 call a week to receiving about 10 calls a day. And that's taken them 10 years to develop through advocacy, through talking, through education. And now with the way that the pandemic has shifted us to talking on Zoom, it really is allowing people to access in more remote areas, ironically. So internet is penetrating across Africa, and that's allowing us all to reach doctors and patients more widely. And so what we're doing is we're manning this. So our allergy center is manning this hotline, and anybody can call this number. And with this, we will give advice on the acute management and care of patients with angioedema. We will help to remind clinicians to think about the diagnosis, to try and make the diagnosis. And really what we hope is that this allows us to pick up more cases. So please feel free to use this and spread this widely. Then I think the other thing that continues to be really great is the ongoing growth of patient advocacy organizations and also the Allergy Foundation of South Africa. That is really, all of these things have come together to continue to talk about these patients, to remind healthcare providers, to remind healthcare funders, and to remind international funders and international industry on the importance of this condition and the need for continued advocacy for improved access. And then also, lastly, with that, there's increasing internet access to a huge amount of resources where both patients and doctors can now get more and more information. And I encourage you all to check out some of these sites and to see what you can find. And of course, you can always reach out to us at our A-Care Center as well. And so lastly, in sort of summary, there's what we're seeing in South Africa certainly is an increasing group of prophylactic and acute treatments that can get us to effective and normal quality of life for patients with hereditary angioedema. The main issue across both South Africa and Africa remains access. And I've just tried to highlight in this talk options that include trials, post-trial access, global access programs, and there's also, of course, compassionate use. And all of that hinges on continued advocacy and continued noise about the condition. And then the other thing, of course, I think is increased awareness of generalists around this condition and recognizing it. And hopefully our hotline will do something to help that. And lastly, I think I would encourage all of you to think about this condition and think about all the research and aspects of primary angioedema across the continent. So even focusing on ACE inhibitors and other related conditions that will all help to make a difference. And I think in closing, I would just like to say that I think if we all work together on this, we can really help to move the needle. Thank you all for your attention, and I look forward to taking questions.
Hello, I am back with a group of eminent professors and eminent speakers, very close friends, who are going to tell us all about what isolated us yet kept us connected the way we are now. So a lot about COVID, especially in our primary immunodeficiency patients. I have the pleasure to introduce Professor Jean-Laurent Casanova from New York and France. And then we will have Isabelle Meyts, chairperson for ASID. So if I may, if we may have Professor Jean-Laurent's presentation, please.
Well, thank you for inviting me to give this conference. I'm delighted to share with you data that have been generated in our lab and in our consortium, the COVID Human Genetic Effort, over the last 18 months. We will be discussing our attempt to decipher the genetic and immunological underpinnings of life-threatening forms of COVID-19. The problem, as you all know, is that of individual clinical variability in the course of SARS-CoV-2 infection. Develop a silent or a mild condition. 70%, 20% of patients developed a non-hypoxemic pneumonia, and a little bit less than 10% developed hypoxemic pneumonia requiring hospitalization. 2-3% require admission to an intensive care unit because of acute respiratory distress syndrome or other types of organ failure. So early on last year, the epidemiologists discovered that the main risk factor is age. The risk of life-threatening disease doubles every 5 years. The other risk factors, including being a man, are much more modest, with odds ratios that are almost always less than 1.5. So age is the key risk factor, but there are women who died in their 20s and men who are centenarians and who've done well. So the key question is, what is the cause of lethal or life-threatening COVID-19 pneumonia? I will focus my talk on pneumonia. I will not discuss the other forms such as MIS-C. The hypothesis that we've put forward early on with Helen Su and the other members of the consortium is that in patients previously healthy, especially patients younger than 60 years of age, there might be life-threatening COVID-19 due to inborn errors of immunity. There are different colors. The rectangles have different colors because we also hypothesize that there can be genetic heterogeneity, that is, mutations in different genes are responsible for life-threatening pneumonia. So to test this hypothesis, we've enrolled as many patients as possible in participating centers that have shipped blood samples and clinical phenotypes to sequencing hubs represented on the slide here. And these hubs have sequenced the exome or genome of the patients while collecting clinical information. Today, I will focus on the two groups of infected individuals that have been useful for our study of pneumonia, namely patients with critical pneumonia, that is either receiving more than 6 liters per minute oxygen or being intubated or ventilated, versus patients infected without pneumonia, that is the asymptomatic and mild forms. The first hypothesis we tested is that influenza and COVID-19 pneumonia might be allelic. Over the last 7 years, we and others had shown that children previously healthy with life-threatening influenza and pneumonia may carry inborn errors of type 1 interferon with mutations in RF7, toll-like receptor 3, or RF9, the products of which are shown in red on the slide. These are the 3 core influenza susceptibility genes that we considered. We've also considered an additional 10 genes, the products of which are represented in blue, that are biochemically and immunologically closely related with the 3 influenza susceptibility genes, and whose mutations in humans, germline mutations, underlie other types of severe viral illnesses. The loop, the circuit you see here, is that of toll-like receptor 3 and RF7 dependent induction and self-amplification of type 1 interferons. It is important for both cell intrinsic immunity, because all cells of the human body express one or another type 1 interferon and respond to them. And also innate immunity, because plasmacytoid dendritic cells in the blood are the most potent type 1 interferon producing cells among these 400 or so discernible cell types. To cut a long story short, and without bombarding data that were published in October of 2020, we found 23 patients, about 3% of this cohort, with dominant or recessive disorders at these loci. I want to stress 4 patients who surprisingly have autosomal recessive RF7 deficiency or autosomal recessive IFNA1 deficiency. The surprise is not so much that they confirm our hypothesis, but their age, because they are 26, 38, 49, and 50 years of age, and they had never been hospitalized for a severe viral illness, including influenza in particular. Nonetheless, these data clearly indicated that influenza and COVID-19 critical pneumonia can be allelic at these loci, that type 1 interferon is essential for host defense against SARS-CoV-2 in the respiratory tract, and seems to be, at least in these patients, surprisingly largely redundant for host defense against other viruses. The clinical implications of these findings were obvious. You can consider treating these patients with either form of commercially available type 1 interferon. You can diagnose these defects in patients and their relatives by exome or genome sequencing. And of course, by providing proof of principle that type 1 interferon are essential for host defense against SARS-CoV-2, these results suggested that other genes upstream or downstream of type 1 interferons might be mutated in other patients. But while pursuing this candidate gene approach, we also did a genome-wide approach, testing whether there's an enrichment of rare non-synonymous variants in the genome of patients with critical pneumonia versus infected asymptomatic or mildly symptomatic subjects. And the result of this so-called burden test is shown here for the X chromosome. And what you see is that there is one gene that pops up well above the level of statistical significance, and this is toll-like receptor 7. Toll-like receptor 7 carries mutations in the patients shown in red on the upper panel, and on the lower panel you have a distribution of all known non-synonymous toll-like receptor 7 patients, variants in patients in public databases, and in blue in previous reports. What you see is that most patients carrying toll-like receptor variants with critical disease in our cohort actually carry loss of function variants, that half of the 8 variants previously reported are actually loss of function, the other half not being deleterious, and that the cumulative allele frequency of loss of function toll-like receptor 7 variants in men is around 5×10 to the -4, which of course is consistent with what we know of the prevalence of COVID in patients, especially younger than 60 or 65 years of age. Here is a description of the 14 patients, 13 of whom are younger than 60. They originate from a variety of countries, consistent with the international nature of our consortium. And as you see, 13 of them are younger than 60 years, which again is consistent with our previous observation that inborn errors of the Toll3 and RF7 dependent type 1 interferon was particularly enriched in young patients. In the experiment shown here, we rescue the deficiency of a patient's EBV transformed B cells to respond to a toll-like receptor 7 agonist with a wild-type copy of toll-like receptor 7, proving that the alleles are not only deleterious when tested by themselves in isolation, but that the toll-7 genotype as a whole, in the context of a patient's genome, is actually deleterious. We then turn to the patient's myeloid cells, attempting to decipher the pathogenesis of critical COVID-19 in patients with toll-like receptor 7 deficiency. On the left, you have a set of data confirming that human toll-7 is highly expressed on plasmacytoid dendritic cells, also a few other myeloid cells and B cells, whereas toll-like receptor 8, variants of which are not enriched in our cohort, is not expressed on plasmacytoid dendritic cells. And as I alluded to earlier, the plasmacytoid dendritic cells, the PDCs, are by far the most potent type 1 interferon producing cells in the human body. Previously, our collaborators, Ali Amara and Vassili Soumelis, had shown that human PDCs critically depend on the toll-7 and toll-9 pathway for induction of type 1 interferon in response to SARS-CoV-2, while we published years back that it is not the case for influenza virus. So we tested the patient's PDC for their response to an agonist and an agonist of toll-7 versus, as positive control, an agonist of toll-like receptor 9. On the left, you see that the patients do not respond to CL264, but respond to CpG, confirming that they're toll-7 deficient. And on the right, that the PDCs do not diversify when stimulated by the same toll-7 agonist. But more importantly, we analyzed the production of the induction at the genome-wide level of transcripts upon stimulation of the patients versus control PDCs with SARS-CoV-2. And this genome-wide analysis shows that they are very poorly responsive to SARS-CoV-2. You have the complete analysis on the left. In the central panels, you have the reads at the type 1 and type 3 interferon loci. And on the right, you have the confirmation of these data at the protein level. So all in all, what we show here is that human toll-like receptor deficiency, an X-linked recessive deficiency, accounts for about 1 to 2% of men with critical COVID younger than 60 years. It is interesting that by a genome-wide approach, we again find a gene controlling type 1 interferon, but this time COVID-19 is not allelic with flu because toll-7 deficiency does not underlie influenza, critical influenza. So the candidate gene approach with influenza as a starting point and the genome-wide approach both converged, stressing that in patients younger than 60 years, inborn errors of toll-3 or toll-7 dependent type 1 interferon is critical for host defense against SARS-CoV-2 in the respiratory tract. We see genetics as a compass, and having made this discovery, we tested the hypothesis that there could be perhaps other ways to disrupt type 1 interferon immunity, not directly through single gene lesions in type 1 interferon-related genes. And we tested the hypothesis that perhaps pre-existing autoantibodies neutralizing type 1 interferons may underlie critical COVID-19 in other patients. What are these autoantibodies? Well, they were described from the 80s onward in patients treated with either commercially available form of type 1 interferon. They were also documented in women with lupus erythematosus, in patients with thymoma, myasthenia gravis, and in nearly all patients with APS1, autoimmune polyendocrine syndrome type 1, due to germline mutations in AIR, the gene that controls the thymic expression of peripheral antigens and thereby contributes to the negative selection of thymocytes. In all these patients and conditions, these autoantibodies were known, but they were thought to be clinically silent. There is one exception. In 1984, the late Ian Gresser had reported a 67-year-old women with very severe VZV infection and highly neutralizing type 1 interferon O2 antibodies. So we tested the hypothesis that such O2 antibodies may contribute to critical disease and found that 10% of patients in our cohort actually carry such O2 antibodies that were not found in patients with asymptomatic infection. Most patients with O2 antibodies were men, and most of them, unlike patients with inborn errors, most of these patients are older than 65 years of age. After we reported these findings in October 2020, they were independently replicated by many investigators in different countries. So at least 10% of patients, especially patients older than 60 years, carry O2 antibodies that are clinically silent until the neutralization of type 1 interferon upon infection with SARS-CoV-2 results in a poor control of the virus and pulmonary failure. So we then tested the possibility that this might be only the tip of the iceberg. And we started with two simple questions. The first one is, how about patients with APS1 who we know have O2 antibodies from the first year of life onward? And through an international survey, we found that the vast majority of APS1 patients infected with SARS-CoV-2 ended up in the intensive care unit, confirming that for a well-defined genetic condition, the O2 antibodies pre-exist SARS-CoV-2 infection. They're not triggered by the coronavirus, and they're causal of critical COVID pneumonia. We then tested the possibility that these O2 antibodies might underlie other viral illnesses, and we found that they account for about a third of the adverse reaction to the live attenuated vaccine against yellow fever. Two other questions that are now in press is whether the first one is, could these O2 antibodies that we detect in the blood, can they be found in nasal secretions? And can they inherit type 1 interferon immunity in the corresponding mucosae? And the team in Lyon documented the O2 antibodies in the nose of patients and documented that upon infection with SARS-CoV-2, there was a downregulation of ISGs, that is, the type 1 interferon O2 antibodies early in the course of SARS-CoV-2 infection have a local impact, further suggesting that they're causal of disease. And the team in San Francisco, led by Jimmy Yee, Mark Anderson, and Joe DeRizzi, analyzed patients with and without O2 antibodies to type 1 interferon admitted to their ICU, and found that they were not only clinical phenocopies, but also immunological phenocopies by an in-depth analysis by single-cell RNA-seq, confirming or suggesting that there is a convergent mechanism and that type 1 interferon deficiency, regardless of its cause, is the driving mechanism in patients with critical COVID-19 pneumonia. Now, having made these points, we more recently tested the possibility that there could be more patients with neutralizing O2 antibodies in the general population and among patients admitted to the intensive care unit. We upscaled our protocol to detect these O2 antibodies, and in the first step, testing more than 30,000 healthy subjects, we found that these O2 antibodies are around 0.3, 0.4% until age 65. From the age of 65 onward, there's a massive increase in their prevalence. After the age of 70, they're about 4%. It is, as you see on the right-hand side, the rise is a little bit earlier in men than women. After the age of 85, they seem to decrease, perhaps because the corresponding patients die of viral disease. We then tested the possibility that O2 antibodies to lower concentration of type 1 interferon might be more frequent. And instead of testing the neutralization of 10 nanogram per mil, of plasma diluted 1 in 10, we tested the neutralization of 100 picogram per ml. And what you see on the slide here, for one patient on the left and for a population of patients on the right, is that there's about 50 to 80% more patients that can neutralize 100 picogram when compared with 10 nanogram. You have here the distribution of these O2 antibodies in almost 3,000 patients with life-threatening COVID pneumonia. It is, as you see, closer to 15% on average, as opposed to the 10% we had found for 10 nanogram per ml. Interestingly, if we focus on patients who died, then the proportion is around 20%. That is, O2 antibodies neutralizing 100 picogram per ml of type 1 interferon account for 20% of COVID death across all ages. We then again ask the question of whether these O2 antibodies neutralizing lower, more physiological concentrations of type 1 interferon might be more common in the general population. And on the left, you see that they are around 1% until the age of 65, and then they reach 4% after the age of 70, and up to 7% in patients 85 to 80 to 85 years of age. So these findings collectively tell us that about 20% and 20% of COVID death across ages are caused by O2 antibodies to type 1 interferon. And they raise the possibility that these O2 antibodies account for other viral illnesses, and perhaps that O2 antibodies neutralizing even lower concentrations might be causal. Overall, the take-home message is that in patients with critical COVID younger than 60 years, there are inborn errors of type 1 interferon immunity, while in patients older than 60 years with critical COVID, there are patients with O2 antibodies to type 1 interferons. Of course, the dichotomy is not absolute. There are O2 antibodies to type 1 interferon accounting for severe disease in young patients, and inborn errors accounting for severe disease in older patients. But overall, 20 to 25% of patients with critical COVID-19 are explained by inborn errors of type 1 interferon, and more commonly by O2 antibodies neutralizing type 1 interferons. These data suggest a two-step model for the pathogenesis of life-threatening COVID pneumonia. Insufficient type 1 interferon during the first week of infection due to inborn errors or neutralizing O2 antibodies accounts for viral spread in the lung and elsewhere. And in the second and third week of infection, leukocytes are attracted to the virally infected sites and are responsible for the massive inflammation in the lung and elsewhere, because they're trying in vain to do the job that type 1 interferon haven't done in the first place. I want to thank the people who've done this work. The first discovery of type 1 interferon immunity was led by Qian Zhang, a pediatrician in the lab. We've had fantastic collaborators. Aurélie Cobat and Laurent Abel have been running the dry lab of the consortium. Helen Su and Luigi Notarangelo were our partners to launch this consortium. Charlie Rice was also extremely helpful to do viral experiments that I haven't shown today. We've also benefited from the collaboration of Ali Amara and Vassili Soumelis in Paris, who studied PDC. More recently, our discovery of X-linked recessive TOL7 deficiency was led by Qian Zhang, Aurélie Cobat, with Takaki Asano and Bertrand Boisson, and the same group of collaborators. The first report of O2 antibodies was led by another pediatrician, Paul Bastard, with the same collaborators. We've also more recently reported the prevalence of these O2 antibodies in the general population, and O2 antibodies neutralizing lower concentrations of type 1 interferon. That again was an effort led by Paul Bastard with Adrien Gervais, Tom Levoyer, Jérémy Rosin, Quentin Philippot. And again, we've had great collaboration with Charlie Rice and Pierre Tiberghien at the French Blood Bank. And that program was led by Aurélie Cobat, Laurent Abel, and myself. Thanks very much for your attention, and I'll be happy to take questions if any.
Okay, one question that we would like to address is whether there were samples collected, or why weren't there samples collected from Africa? Were the barriers mostly ethical, or are there other problems?
Oh, there were samples from African countries. Several African countries are members of COVID Human Genetic Effort: Morocco, Algeria, Egypt, and I probably forget a few others, but at least these three for sure.
Fantastic. So it may be a problem with some of the South African ethics regulations. I'm not sure, but we'll get there. Another question from Kate was,
just as a comment, I don't think there are ethical problems. The main barrier is the willingness of people to collaborate. I mean, it's a good excuse to think that there are ethical or regulatory barriers, but the bottom line is that people who want to collaborate manage to collaborate.
So more communication than anything else, probably.
Well, no, it's not communication. It's just, energy. What we're doing is 1% inspiration and 99% perspiration. That's the reality of what we're doing.
Good point. Okay, then also from Kate, do you think the data support the theory that the male predominance of severe disease may be due to the described ability of females to better produce TLR7-induced type 1 interferon?
Well, I think there are at least two known reasons for the odds ratio which favors women over men in the course of SARS-CoV-2 infection. The first one is that there's at least one X-linked recessive trait, and that's toll-like receptor 7 deficiency, which appears to be recessive and not codominant. And the other is that the autoantibodies to type 1 interferons, especially in elderly people, seem to be a little bit more prevalent in men than women. But there might be other factors, but there's at least these two known factors.
Okay, thank you. Nala, do you want to take the question from Rayan?
Yes, I think, there are two more questions. I think Rayan was asking about, would he recommend standard testing for autoantibodies to the type 1 interferons in all patients with IEEs who contract COVID? Even when they don't have severe disease? Would that, I think
it's a predictor. I think it's a great question. It's easier to find out if you have autoantibodies to type 1 interferon than to sequence your exome or genome. So if you're admitted, let's say if you are epidemiologically in an at-risk population, for example, if you're a man older than 65, the detection of the autoantibodies on day one, the day of diagnosis, whether ambulatory or as an inpatient, that has a huge prognostic value. And so, yes, I would recommend that, absolutely. And it's actually being done. It's actually already being done in many hospitals,
right?
Especially in Europe. You know, Europe has been much more reactive than the US.
So they are well standardized and they are available for routine testing.
Yeah, they're available, you know, throughout many hospitals in Europe and, you know, hopefully elsewhere soon.
Okay. And do you think, her other question is, do you think that these autoantibodies or these defects have a role in patients developing MIS-C?
So we don't know that. It's another great question. That's being studied as we speak.
Excellent. So we'll be hearing about that very soon then. Hopefully. Yeah.
We've been given a pointer here that our time is up for questions. I think there is a lot of interest. Maybe the other speakers and people can get together on the email to Professor Laurent.
Everybody is very welcome to email me. I look forward to these questions. Thank you again for inviting me.
Thank you. Thank you for being here. Thank you. Thank you so much.
Merci.
Hi, I want to first thank the organizers for inviting me as a speaker today. And my topic will be COVID-19 in patients with primary immunodeficiency. So, of course, more than 1 year into the pandemic, this may be old news, but I think it's interesting to see how we started with the international survey we conducted. So, the initial question we had in March 2020 was how to advise patients with primary immunodeficiency on the risks of catching COVID-19. So there were some emerging data from the secondary immune deficiency patient groups, but we really had no clue at that point if, for instance, comorbidities were important for the patient and therefore if patients with PID would be more at risk of severe COVID-19. There was already the idea that patients with specific inborn errors of immunity predisposing to severe viral infection would be particularly at risk for COVID-19. So there were already shielding advices sent out to patients with IRF7 deficiency, IRF9 deficiency, TOL3 deficiency, and so on. But we decided to tackle this question with a very rapid and maybe rather superficial, from hindsight, survey that was led by ASID, IPOPI, and IUIS. So we ended up including 94 cases of patients with primary immunodeficiency who were infected and proven to be so by PCR, showing SARS-CoV-2 PCR positive. And what we actually saw that overall, you see that the mortality was similar to mortality in the general population. Although maybe the ICU admission rate was a bit higher, and also that mortality was maybe more prevalent in the younger age groups of patients. So looking into the individual PID patients that we had included, we had, of course, several with antibody deficiency. The majority had common variable immunodeficiency, 6 had X-linked agammaglobulinemia. There were a couple of patients with combined immunodeficiency, mostly post-transplant or post-gene therapy. There were several patients with autoinflammatory disease, some phagocytic defects, and some cases of immune dysregulation also. So looking into these patients, we saw that basically 35 of 94 had asymptomatic infection and mild disease. So this was significant. If you look at the group of patients here, patients with ALPS-like disease, 2 with Aicardi Gutierrez, that 1 gain of function, a Wiskott patient who had received transplant, a patient with XLA, patient with autosomal recessive A gamma, some hypogamma patients, and importantly, 4 of these patients had quite severe chronic lung disease. 25 patients were mildly ill and were treated as outpatients. And also here, it's important to mention that 14 had predominantly antibody deficiency and 7 had 1 or more comorbidities. So these patients were actually, from a, let's say, general perspective, in a quite severe state before getting COVID-19, and still they did quite well and had only mild disease. So looking into the patients that were hospitalized and that were admitted to ICU, what is important to mention here is that there were 4 females and 11 men who were admitted. And if you look at the distribution of disease, you can see that there's a few NF-kappa B2 deficient patients there, and the rest is actually hypogamma-globulinic. And all of these had actually quite extensive comorbidities. Some were even under treatment for cancer. So if you look at the overall picture and representation of these patients, you see that by and large we had a good representation of the several groups that are represented in IUIS, let's say, classification, and that overall the patients who deceased, you can see them here in the barred light shares, is that actually these patients had mostly but not always comorbidities, and that most of the patients are in the antibody deficiency group, some are in the phagocyte defect group, but overall mortality is well, in this group at least, it was rather comparable to the general population. So the patients who died, so 1 had X-linked CGD and died in the context of severe sepsis with Burkholderia. And I think there's still genetic analysis ongoing to see if there was not an additional defect. 1 patient was died post-transplant, and several others actually had extensive comorbidities, including 1 patient being treated for cancer. So that was the interim conclusion at that point. So you can see we had a case fatality rate in this survey of about 9.5%, which at that time was comparable to the general population. Of course, at that time when we published this in June 2020, we had a huge inclusion bias. Of course, not all immunodeficiencies, individual immunodeficiencies are represented here. There was diagnostic bias because of regional testing priorities. And so, for instance, many asymptomatic infections for sure were not captured here. And of course, the physicians taking care of these patients already imposed strict isolation measures for the patients which may have caused an additional bias. So an additional problem is that at this early time point, MIS-C had not been defined yet, was not described yet. So we could also not really discriminate cases of MIS-C in this cohort. From hindsight, several patients, for instance, a patient with GATA2 deficiency, had actually probably a MIS-C that was hinged upon this COVID-19 pneumonia in the acute setting. Several conditions also, as we learn now, deeper into the pandemic, were of course not identified as inborn error of immunity yet at that time. So it's also difficult to describe any susceptibility of these patients. And then also, of course, there's a huge treatment bias. We cover quite a number of areas in the world, but of course it was impossible in this early survey to cover all the differences. So we were bold enough to think at this point that the presentation, the risk factors were quite similar to the general population, although younger male patients were more frequently severe ill. So the second part of this presentation is really the status in September 2021. And we, together with Stu Tanguy and Georgia Buchol, we counted 600 patients reported until now in literature, diagnosed with a primary immunodeficiency and then infected with SARS-CoV-2. And you can see the different groups here presented. So there was quite a large number of patients with antibody deficiency, XLA, autosomal recessive A gamma, etc., PIK3CD mutations. There was a large group of patients with combined immunodeficiency. Some of these were post-transplant. The ones who were post-transplant usually did very well. Some pre-transplant were mildly ill, but also there were several who actually were critically ill and a few who died. Patients with immune dysregulation, also quite important group with AIR patients, counting 29 here. And the phagocyte defects with CGD, GATA2 deficiency, also as a major group. Innate immune defects also are counted here. I must say, so that we didn't, of course, count the patients that had been unraveled as having underlying innate immune defects due to study when they were infected with COVID-19. So we only counted the ones that already had been ascertained as having immunodeficiency. Then we also looked into the autoinflammatory disorders, which was quite a substantial group, and complement deficiency patients. So looking in all of these different subgroups, we actually could stick to the conclusion that the clinical presentation of the patients is overall similar to that in the general population. About 10% were asymptomatic and 50% had mild disease. But indeed, the age was lower. It seemed that the proportion in ICU was also higher than in the general population. And so overall, this sort of, let's say, reiterated what we had found in the initial study that we reported. Now, looking into the case fatality rate, overall here on the 600 patients, it was 8.1%, similar to the general case fatality rate at that time, because most of these studies were actually conducted about a year ago. And we can see huge differences again per region, with a mortality of 0% reported in Israel to 42% in Iran, mostly also presumably representing differences in healthcare accessibility, but also vaccine outroll programs, etc. Of course, what is important, patients were younger and higher ICU admission rates. So likely if we count and adjust for age, there is a more severe outcome for PID patients, which makes a lot of sense, of course. Most, but not all patients had comorbidities. And what I think is really important, if we look into the general, the groups, if we look into the different classification, we see that AP1 stands out with a case fatality rate of 14.8%. And I think this becomes quite clear in the light of the previous presentation, why these patients are so vulnerable to infection with SARS-CoV-2. So this is a figure taken from the review that Stu Tanguy, Georgia, and I wrote. So overall, if you look into the case fatality rate, it's about 8.1%. Patients with autoinflammatory disorders seem to be a little bit doing a little bit better, and patients with, for instance, air deficiency stand out as really problematic in the battle against SARS-CoV-2. So what can we learn from this? So APS1, of course, probably resembles the crucial role of anti-type 1 interferon autoantibodies. We think we can derive from these data that patients with autoinflammatory conditions fare a little bit better. But despite mild infection, some patients do have chronic relapsing SARS-CoV-2 infection and necessitating in the end some form of monoclonal antibody therapy plus or minus an antiviral. And there's a few papers out, few coming up that really show the benefit of this monoclonal antibody therapy or of convalescent plasma. So difficult to say, of course, if it's not a blinded trial, etc. But the data really points to some benefit for these patients. Then what's there to be said about SARS-CoV-2 vaccination in patients with primary immunodeficiency? And there's two beautiful studies out. There's the one from David Hagen showing 26 patients quite early on that 18 developed specific antibody response and 19 showed an S-peptide specific T-cell response. Difficult to figure out what those T-cell responses really mean against SARS-CoV-2 infection. But I think it has been the approach also for flu vaccine that we consider this a potential benefit, and I think more in-depth research will show us if this is really the case and how important that is in the battle against SARS-CoV-2. And then this beautiful study from Ottavia Del Monte in the group of Gigi Notarangelo recently published, who showed that when studying 46 patients, 27 of the 46 after one dose had already quite good response with anti-IgG production. And it was the case for 85% when they looked into the entire group of fully immunized patients. And what stood out again is that actually only 7 of 11 patients with APS1 produced a good response, probably due to immunosuppression. So from this study, it could be derived that previous use of rituximab T cells or CD3 T cells below 1,000 per microliter and less than 100 B cells per microliter were associated with lower anti-IgG levels. So there were also no mentionings of severe adverse events. So we can conclude that if available, the vaccine is really safe. The mRNA vaccines at least are really safe also to administer to patients with primary immunodeficiency, because most of these vaccines had been mRNA vaccines, and that they really can produce antibody responses in at least a subset of patients. But of course, we are not there yet. We need to learn more. I think it stands clear that there is a central role early in the infection of type 1 interferon response, and that the analysis of autoantibodies against type 1 interferon in the individual PIDs is probably a crucial thing to look into and to study. And hopefully, if we are still facing this virus for a longer time, this could be some way incorporated in a point of care test. Risk of relapsing disease is also an important problem. The potential of monoclonal antibodies for cure and prevention, where available, is something to consider. And I do hope that the general solidarity of the world will improve, so that also regions that are less well, let's say, considered by the vaccine strategies also benefit from vaccination and all the cures that are available for others. Vaccines are safe. Efficacy probably should be monitored to be on the good side. And then the question is, probably soon anti-SARS-CoV-2 IgG will be emerging in IVIG and sub-Q products. They are actually emerging. The question is, to what extent will these be helpful in providing, let's say, sustainable protection against infection? Will the levels be high enough? How will we monitor that batch per batch? And I think this is going to be a very important point for the near future. So with this, I would like to thank you, all of you, for attending and for listening. I would like to thank Georgia Butchol. I would like to thank Stu Tanguy, all the physicians who contributed to the study, all the societies studying patients with primary immunodeficiency, the patient organization, and I would also like to call you all to register patients in the COVID-19 study that is still ongoing, and also to contribute, if you can, for more in-depth study of patients that are previously healthy, severe COVID-19 patients, because I think this will really help us all to decipher known and novel inborn errors of immunity in the context of COVID-19. Thank you.
Thank you very much, Isabelle, for a fascinating talk. Second one that's really very enlightening on this topic. I just have one brief question, and that is the patients that have a defective vaccine response, our IEI patients. How do we approach them, and also the patients who've been on rituximab? Any ideas on strategies how to revaccinate them?
Yeah, and that's a very difficult question. I think there's no good strategy because rituximab use recently, and as you saw, the B cells below 100 per microliter are really a risk factor, or at least associated with a very poor response in terms of neutralizing antibodies. So I think once we're in that group of patients with inborn errors of immunity, then I think we cannot design a good strategy per group, but we have to do it individualized and almost monitor the response, although that is a very difficult job. We can hope that the products, let's say the IGs that will be coming out will contain neutralizing antibodies, but the question is that we don't know what level we need to achieve in those antibodies before we are really protecting our patients. And then there is hope with monoclonals that will be protective for several months. So that could be very good, of course, solution, very expensive probably also, but that would be a very good solution for some of the patients. But I have a lot of hope that soon there will be some antibodies in the, and it's already, there's papers out. So I hope that soon when let's say the plasma donating population is more vaccinated, that we will have some basal protection for the patients. But yeah, I think it's trial and error and very individualized.
Yeah.
Thank you very much. Thank you.
There's another question that has just come through from Kate Webb. She's asking what would be your recommendation about waiting for vaccinating kids who are receiving IVIG?
Well, I guess the answer builds on the previous answer, because at this point we don't have any data to show that whatever level of neutralizing antibodies in the IVIG or sub-Q product would dampen the response to the vaccine. So I would not withhold the vaccine to patients receiving IVIG. We can also have some T-cell responses. We don't know yet what that really means, but I think that's what we've been doing with flu shots, etc. So I don't think we should do it any differently. Again, that's my opinion. There's no good written advice as yet, but I think that's basically what we need to adhere to until we know more. And there are several studies going on, larger studies. The one from the UK that hopefully will soon be published will also teach us something. But I think if we merge all those data, we will have some more idea of what to do. But until then, we're agnostic. We don't know. And then I think we have to act as if the way we act with other vaccines, namely administer them because they are, in my opinion, safe. And I think we can administer these also to the patients under IVIG. The response, that is another question.
Well, it is interesting that the only patient that I have had some serology for by mere chance had positive antibodies, and he was a specific antibody deficient kind of child with,
Sorry, I didn't catch that question, sorry.
No, I said it's just interesting how we had one of our patients having a positive response to natural COVID. By antibodies, basically.
Yeah. And you see also, if you look at the data, and especially in children, they don't seem to be at very high risk, though the singular patients that do get really ill and land in ICU or die, well, there we did not do a good job for these patients. So I think to protect, because we don't really know, we know from the studies of Laurent, of course, but this is not the population that we are looking after day, except for the air deficient patients. But the rest of the patients, we don't know that much about yet. And I think also measuring indeed anti-type 1 interferon antibodies in that population, it could really teach us something. why
right.
some combined immunodeficiency patients are more prone to severe disease than others, why CVID patients, etc. I think the answer could also, at least in part, be in those autoantibodies or in other dysregulation of the immunity. Yeah.
I think we'll have to, unfortunately, close the questions here. Now they're coming, but
now there are too many questions.
But I think some of them have been answered specifically to PID patients, but the vaccine one is a very common one from the patient point of view, I think.
Absolutely.
Yeah.
So
maybe we can combine some later.
Yes, and we will go on to the introduction of the next speaker.
Thank you.
If I may go ahead with that, it's A.Sobh. Ali, I have not had the pleasure of meeting you personally yet, but we've worked on guidelines. So it's very nice seeing you now on the camera. You're a lecturer and consultant in pediatric immunology in Egypt at Mansoura University, and we're looking forward to your talk, COVID-19 in patients with PID, the African experience. Thank you very much.
Hello, I am A.Sobh, pediatric. Hello, I am A.Sobh, pediatric immunologist in Mansoura University Children's Hospital. I'm happy to talk to you today about COVID-19 in PID patients, the African experience. COVID-19, since it appeared in China in December 2019, till now it caused more than 231 million cases. And more than 4.7 million deaths all over the world. Although most people will recover spontaneously with supportive care, but worse outcome is noted in patients with underlying health conditions, including immune-compromised patients. In patients with no underlying health condition, hospitalization rate is about 29%, while the ICU admission is 22%. And patients with underlying health condition, the hospitalization rate is 71%, and the ICU admission rate is 78%. The main objective of this study is to assess the burden of SARS-CoV-2 infection among African PID patients. We aim at identifying the PID categories mostly affected by COVID-19 infection and describing the clinical presentation of COVID-19 among African PID patients. We also want to identify the treatment modalities and the outcome of COVID-19 in different categories of inborn errors of immunity. We designed a web-based survey using SurveyMonkey and distributed it to African pediatric immunologists who are treating patients with inborn errors of immunity. The questionnaire inquired about demographic data, COVID-19 presentation, treatment, and the outcomes in patients with inborn error of immunity, according to current diagnostic guidelines and most recent IOIS classification in 2019. The survey opened in June 1st, 2021, and closed on July 31st, 2021. Data exported and analyzed using SPSS version 22. We received data for 32 patients. 24 of them had either PCR positive for COVID-19 in 23 patients, and positive serology in one patient only from Sudan. The other patients with PCR positive, 13 from Egypt and 2 and 10 from Algeria. The median age for patients was 11.5, with 70% of them males, and median age at diagnosis was 6 years old. The predominant category of PID affected with COVID-19 was a patient with predominantly antibody deficiency, 50% of cases. followed by combined immune deficiency with associated or syndromic features and affecting cellular and humoral immunity respectively, with 17 and 13%, followed by fewer number of cases with autoinflammatory congenital defect of phagocytic number and disease of immune dysregulation. The most specific diagnosis affected was CVID, followed by congenital agammaglobulinemia, ataxia telangiectasia, CGD, and then one case for each severe combined immune deficiency, Mendelian susceptibility for mycobacterial disorders, hyper-IgM, hyper-IgD syndromes, blockade deficiency, and ER. The most prominent comorbidity of this patient was chronic lung disease, which is another major risk factor for severe COVID-19 infection in the general population. 23 patients didn't have any other comorbidity. 5% have chronic liver disease, and incidental finding of hydrocephalus and unilateral kidney in some patients. The most predominant manifestations were fever, followed by cough, which is the same as general population, followed by shortness of breath, headache, diarrhea, and some cases also showed rhinorrhea, loss of taste and smell, vomiting, abdominal pain, and myalgia. Only 7 patients showed severe manifestations. 2 patients have sepsis, 2 acute respiratory distress syndrome, 2 patients with both sepsis and acute respiratory distress syndrome, and only 1 patient with a multi-system inflammatory syndrome of children. The relation between category of PID and mortality, the most predominant cases was hospitalization and mortality were either predominant antibody deficiency or combined immune deficiency. And this can be explained by these 2 categories comprise the most number of cases we received or reported. Other few cases with immune dysregulation, congenital defect of phagocytic dysfunction, and autoinflammatory disorders are very few numbers to interpret this data like other cases. Regarding the treatment of PID at the time of diagnosis, most patients received antibiotics and IVIG, and this actually depends on the underlying PID diagnosis. Few patients received antiviral, antifungal. Only 3 patients were maintained on immunosuppressive therapy like steroid, IL-1, anti-IL-1, and methotrexate, 1 for each. 9 patients received treatment at home. Hospitalization was required in 15 patients, which comprise about 62% of cases. Oxygen therapy required in 12, ICU admission, 6, mechanical ventilation, 4 of them, and 2 received remdesivir. 19 patients received steroid and IVIG. 1 patient only get tocilizumab. 18 patients received antibiotics, and 2 patients received antibiotics. Here we will talk a little about in details about patients with severe manifestations. Patient 1 diagnosed with DIRA was diagnosed at age 1 year and presented with COVID-19 at age 4 years. At the time, was maintained on a non-steroidal and methotrexate. Anti-IL-1, unfortunately, is not available in Egypt. No other underlying health condition, but unfortunately, he progressed to sepsis and acute respiratory distress syndrome and died. We have 3 patients who presented for the first time with the COVID-19 diagnosis. The first one was patient number 2, patient with hyper-IgM, who presented at the age of 1.5 year with multi-system inflammatory syndrome, and then by immune evaluation, history taking and evaluation, he was diagnosed as hyper-IgM syndrome, and we sent blood for him for genetic testing, but waiting results. The good news, he received IVIG aspirin and he survived with no cardiac sequelae. The second patient with first presentation with COVID-19, patient number 4. The patient with this kid presented to Ain Shams University in Egypt also, Children's Hospital, and presented with pneumonia, received the IVIG, required mechanical ventilation, and he survived. The third patient whose first presentation is with COVID-19 is patient number 5 with CVID, presented at the age of 7 years, presented with pneumonia, but unfortunately progressed to sepsis and died. Regarding patient number 3 with DOCA deficiency, diagnosed with PID at the age of 7 years and presented with COVID at the age of 11 years, underlying comorbidity with chronic hepatitis and progressed to ARDS and sepsis and died. Patient number 6, he is an adult, 39 years old, presented at age 37, diagnosed actually at age 37, and was maintained on IVIG, and also died with acute respiratory distress syndrome. The last patient was gamma globulemic. He was diagnosed at the age of 6 years and he's presented with COVID-19 at age 16, was maintained on IVIG at the time. He has underlying risk factor, which is chronic lung disease, and died with acute respiratory distress syndrome. We have only one patient who was persistently PCR positive with follow-up and after resolution of all symptoms of COVID-19. This is an adult patient with CVID who was diagnosed at the age of 40 years and presented COVID-19 at 46, was maintained on IVIG at the time. He developed pneumonia, received the IVIG and steroids, and he is alive. This is a short comparison between our study and other studies. We will see that most studies have small number of cases, like the Israeli study, the Iranian, Turkish study, and also our study, all about 24, 26. The largest number was presented by the ASID study, 94, and the Brazilian study, 121. As we see, most affected category is the predominant antibody deficiency in all studies, in most studies, representing from 52 and more percent of cases in most studies. Patient required hospitalization. In our study, were 62%, and the same for the ASID study. It was a very high percentage with the UK study and the Iranian study, but a smaller with the Turkish and Brazilian one. For the Israeli study, actually it showed very low impact on patients with PID. All of them received the home treatment and no mortality at all. The mortality in our study was about 21% of cases. In the ASID study was 9.5, 20% in the UK study, 42 in the Iranian study, 7.6 in the Turkish, and 6% in the Brazilian study. Our conclusion, although primary immunodeficiency is considered a risk factor for severe disease and the mortality of COVID-19, there is a big variance between different studies, ranging from low to high fatality rate and poor outcome. Our study showed a mortality rate of 20% and severe disease in 30% of cases. The main underlying factor of mortality is presence of chronic disease, especially chronic lung disease, which is similar to other studies and also to general population. The main limitation of this study is the small number of patients, 24 only, which is mainly due to low rate of PCR testing in most African countries. Further and multi-center international studies are required for better estimation of the burden of disease among patients with inborn errors of immunity. I would like to thank Dr. Nahla Erwa and Dr. Rimelfi for supervising this work and actually did a lot of work editing and advising. I also would like to thank colleagues who send us their data. Reda from Algeria, Andre from South Africa, Brahim from Algeria, Dalia Nisreen and Rasha from Ain Shams University from Egypt, and also Reda Shosha Endo from Senegal. Thank you.
Yes, thank you very much, Ali, for this talk. At least we have some limited information about what happens to patients with COVID-19 in Africa. And obviously we need more data on this. The mortality was quite disturbing, but maybe that was a selection bias as well. There are two questions apart from this. Was anti-type 1 interferon antibody measured in any of these patients?
No, because actually for Egypt, we have 13 patients from Egypt. This test is not available in Egypt. And actually, I communicated with Dr. Casanova because we are participating in his study. But I asked him to do the anti-interferon antibodies for the Egyptian patients. And actually, he agreed to help us with this. So we're preparing to send a lot of serum samples from COVID-19 patients from Egypt. But the test is not available. From other countries, actually, we didn't add this item to the survey. So we don't know if they do it or not.
Thank you very much. I'm glad to hear you're part of that participating study, because I have the feeling a lot of patients are not coming forward with the diagnosis. They've stayed out of hospital if they can. So I think there are lots more of our IEI patients that actually had COVID-19. I heard anecdotally afterwards from some of our patients, unfortunately did well.
Actually, we are participating. We are participating in this study for all patients with COVID-19, not only the PID patients. We send them samples from all patients diagnosed with PID. They analyzed about 30 samples now from Mansoura, and we sent other number of cases, but we didn't get the results in the published papers yet.
There was one other question. How many patients had MIS-C? And did any others of them have coexisting bacterial infections?
Only one patient in this survey was MIS-C. And this patient also had a coexisting bacterial infection. Because this is our patient, he actually presented to us with a classic picture of MIC. And then when we did immune evaluation and by his history, and we re-evaluated him even after 3 months, he has a classic picture of hyper IgM. And we sent samples from him specifically to do the genetic testing for which type of hyper IgM syndrome. And he had also bacterial infection, but he survived. He did well with IVIG and aspirin as a treatment for MIC, and received antibiotic, and he's now following with us and doing well on monthly IVIG and antibacterial prophylaxis.
Thank you very much. Thank you for answering these questions. If we have no further questions here, then
yeah, there was a question.
Want to go back there, Nala?
Yeah, there was a question that I kept here actually about the management of PID with persistent COVID.
Yes.
Yeah, the other one was on effectiveness of vaccines, and that was included in previous answers. So I think that's the only one that left from previous talk.
So yeah, persistent COVID-19. So there are some data, I think, I'm not sure it's already published, but it will be published soon, from Klaus Warnatz and also from David Lowe in the UK, showing that patients with actually relapses and persistent COVID-19 PCR positivity with symptoms actually benefited from monoclonal antibody therapy. In the UK study, this was in combination with remdesivir. And I think also in the study of Klaus, there were some patients who improved after having received convalescent plasma, but definitely this is a major trouble for these patients, because some of them have mild symptoms, but some of them do continue to have severe symptoms. And it seems that here probably monoclonal antibody therapy did really benefit for the patient.
Maybe
and
I
then,
can.
Interesting.
And yeah, of course,
yes.
The company up till now, the companies up till now are really, let's say, very, very happy and very, very working together with the physicians to treat the patients. So I think that we can be grateful for that at least we were able to give that to some patients in the community. But of course, if we're going to treat many patients with this, it's going to be yet another important burden to society and to cost, etc. And I think also another, in some patients, there has been an improvement after getting the vaccine. But of course, then you need to be sure that this is a patient who will respond in one way or another. And this needs to be monitored. Is this T-cell response? What response is this then, you know? So I don't know. But I think there's definitely evidence out for the monoclonal antibodies that they work.
I have another question linked to the chronic persistence, but not so much somebody is symptomatic, but a group of patients that is immune suppressed, and they just seem to keep on carrying virus and stay infectious, even though they're asymptomatic. I don't know whether we actually actively screen for that in our IEI patients, but they are a continued reservoir. And the question comes up, obviously, although whether our HIV immune suppressed patients are adding to the reservoir. But I don't think there are enough data out on that, and that could be quite worrying.
Yeah, I don't know, Ali, for your group, but we, in the study that we published in the Journal of Allergy and Clinical Immunology, we had some data, but because we didn't have it for all the patients, it was not consistently well monitored, we didn't include them, but there were patients who definitely had positive PCR, even if they were with mild disease or asymptomatic, until 20-40 weeks. So so it can be a long time. And that is also one of the hurdles, because these patients are being isolated all the time. They cannot go out because they're continuously positive. So I don't know. I think also there the monoclonals will help, but again, weighing the balance between the costs and etc. I think vaccines do always make sense, but of course the patient has to mount an immune response, otherwise it won't help. I don't know if anyone else on the panel has a better idea, but I think we're still waiting for better data to know what to do with these patients.
Would there be any rationale if there's some response to keep revaccinating? Might be a cheaper option. If it's safe.
Definitely a cheaper option, and I think because it's mRNA and it's linked to a protein or at least a peptide, I don't think there's going to be a dampened response after repeated boosters, which is a problem that you can have with the polysaccharide vaccines. But yeah, I don't know. I really don't know if anyone ever tried to do it, and then N is 1 doesn't mean anything, right? So.
So let's conclude this by saying that COVID is changing epidemiology and understanding of disease. And we'll be seeing a bit more as studies come along. Yeah. Just being warned that we have to move on, I think.
Yeah, okay.
Thank you very much.
Thank you.
Thank you. Thank you. Bye.
Merci Isabelle, c'était formidable.
Thank you very much. It gives me great pleasure to introduce Janet Chu, who will be talking to us also on the topic of MIS-C in the range of COVID-19 related topics. She is a scientist, pediatrician from Boston Children's Hospital, a very active clinical immunologist, and we look forward to her talk. Thank you very much.
Thank you very much for the chance to speak to you all. I'm going to be speaking about multisystem inflammatory syndrome in children, or MIS-C. And as you all know, there's been a tremendous amount of research on this disease. So the way I've structured the talk, I will present some data that's come out of Boston Children's and my lab, as well as collaborations, but really placed within the context, a larger context of the fantastic work that's been done worldwide on this disorder. So as you all know, MIS-C is a systemic inflammatory syndrome in children under 21 years of age. And it is, the diagnosis hinges on that it occurs within 4 weeks of SARS-CoV-2 infections. And the children will present with fever and laboratory evidence of inflammation affecting at least 2 organ systems that is severe enough to warrant hospitalization. And this occurs in the absence of any other identifiable cause, of course, because these diagnostic criteria are not completely specific for this disorder. The reports of it first came out of Italy and Bergamo, followed by reports in the UK, and finally then in New York, and subsequently has spread throughout much of the world, although it has been noticed that despite the clinical overlap of this disorder with Kawasaki disease, the cases coming out of East Asia, China, Japan, which have some of the highest rates of Kawasaki disease, have been less than expected. So as Professor Meyts has alluded to, there is clinical overlap between MIS-C and severe acute COVID-19. I show here on the left a graph from the Centers for Disease Control and Prevention showing that in the United States, we have here in the dotted line, the cases of COVID-19 that are spreading from February 2020 to May 2021. And in blue, you see the cases of MIS-C trailing behind. So this supports the hypothesis that this is a post-infectious syndrome, that it is indeed distinct from severe acute COVID-19 in the fact that it trails behind the cases here. There have been a number of large multi-center epidemiologic studies searching for risk factors and characterizing this disease, and I've highlighted several of them here. In one of the first to come out, led by Adrienne Randolph at Boston Children's and her 80-site Overcoming COVID-19 study, they found that the risk of MIS-C was higher in patients who are school-aged, so 6 to 12 years of age, non-Hispanic Black compared to white in the United States population, and previously healthy, which is in contrast to the association of acute and severe COVID-19 with children that have chronic medical conditions such as chronic lung disease or tracheostomies. There was a follow-up study published by the same group in JAMA that looked at some of the clinical and laboratory features associated with MIS-C in comparison to those associated with COVID-19. And they found that those with MIS-C had a greater neutrophil to lymphocyte ratio, a lower platelet count, and a greater CRP. More recently, because all of these studies are based on clinician diagnosis, the same data set was used, studied using a machine learning algorithm, hospitalized on these patients hospitalized with SARS-CoV-2 related illnesses. And in this case, the goal was to use an unbiased or computer-based approach to see if they could distinguish the features that were more highly associated with MIS-C rather than COVID-19. And this machine learning approach supported what has been found clinically, that is to say that the patients with MIS-C tended to be previously healthy and presented with more frequent gastrointestinal involvement, whereas those with COVID-19 had chronic medical conditions and more frequently had respiratory system involvement. So much work has been done to understand the mechanisms underlying this disease. And so people have first started with their clinical phenotypes, the similarities and dissimilarities from other immune disorders, and worked backwards from there. So some of the major clinical features of this disease are the myocarditis, the coronary artery aneurysms that are known to be associated with Kawasaki disease, the diffuse immune cell overactivation that is reflected in both cytokines as well as on a cellular basis, and this overlaps with cytokine storm syndrome such as macrophage activation syndrome, and the severe hypotension that some patients present with that may resemble toxic shock in some patients. And so looking at these clinical entities, investigators have looked back and studied to see if there are cross-reactive T cells and antibodies to either other viruses or other organs that are driving this disease. People have looked for specific cytokine signatures characteristic of MIS-C, and they have looked for expansion of specific T cell receptor clonotypes. So I will briefly go into this now with some of the studies that have been published. So at Children's, we have a large historical cohort of patients with Kawasaki disease dating to before the pandemic. And so these were used to see if we could determine differences between those who have MIS-C versus those who had pre-pandemic Kawasaki disease. This work was done by Pui Lee and Megan Day-Lewis and led by Mary Beth Sun, who are all in the rheumatology section here at Children's. So you can see here on the left that those with Kawasaki disease really don't have as severe a cytopenia. So those with MIS-C have a lower white blood cell count, lower ANC, lower ALC, and platelets. And so when they looked at sort of other features such as inflammatory markers here, the CRP and ESR, there's a much broader range for those with MIS-C. This is likely because we had started treating patients with MIS-C with IVIG on the premise that they seemed similar to Kawasaki disease even before the guidelines had been more standardized. So subsequent to that, there have been a number of studies, I highlight just two here, that have looked at the cytokine signature of patients with MIS-C versus those with Kawasaki disease. And you can see that there's quite a divergence in the cytokine signatures that have been identified. In this upper study here, published in Cell, you can see that those with Kawasaki disease actually had higher inflammatory cytokines that they measured, so IL-6, IL-17, and CXCL10, which is a marker of macrophage and myeloid cell activation. Whereas a second group here, published in JCI, found that those with MIS-C compared to those with Kawasaki disease actually had higher inflammatory markers, and these included SDF1, IP10, interferon gamma, and others. So, and this has sort of been borne out in subsequent studies as well, and part of these differences arise from the fact that this is all research done in the middle of a pandemic. So patients are going to be treated regardless of their research study, their observational studies, and some of these patients, many actually, will be pre-treated, leading to sort of this big range in inflammation. And also, there will be differences in the time of presentation and when they're actually enrolled in the study. So all of that will contribute to some of this variability. That being said, collectively, the studies really have shown that MIS-C does have a diffuse elevation in cytokines, but there's no singular cytokine signature associated with this disorder. So early on, we also looked to see the differences between MIS-C and patients with macrophage activation syndrome, because the cytokine storm piece was a big characteristic of this disease. As you all know, there are many factors that lead to the cytokine storm that ultimately culminates in MAS. These include genetic risk variants, infections, and rheumatologic diseases such as systemic GIA and Still disease. So here we had found that in our cohort of patients with MAS at Boston Children's, that those with MIS-C really had lower inflammation. So lower levels of soluble IL-2 receptor, which is a marker of T cell activation, ferritin, IL-18, and CXCL9, which reflects type 2 interferon signaling. This is not a huge surprise because patients with MAS often need very strong immunosuppressant, sometimes etoposide, pulse dose steroids, which is higher than what is required for control of MIS-C. So more recently, multiple independent groups have been looking to see if patients with MIS-C exhibit any specific TCR repertoire or an expansion of a TCR clonotype. I've highlighted here 3 studies right here and shown the image from one of them, which really you can see that the patients with MIS-C here shown in green, they do have an expansion of the V beta 21.3 TCR, and this was commonly found to all 3 of these studies. And you can see how distinct this is from patients with Kawasaki disease, where there is not a majority of patients with an expansion of any given TCR. Same for COVID-19. Toxic shock syndrome, of course, one would expect expansion of the TCR repertoire, but you can see here, it's down here below, and it is distinct and different from that which is expanded in the patients with MIS-C. So this remains an active field of investigation, but at least suggests that there is an polyclonal expansion of T cells with a specific TCR. There have been a number of studies that have compared pediatric COVID-19 to MIS-C and MIS-C to adult severe COVID-19. So I've really synthesized all of them in this figure, which is to say that in both pediatric COVID-19 as well as MIS-C, there is what I would call immune synchrony. So there's crosstalk between activated T cells, B cells, secreting cytokines, increased antibodies levels, and expansion of plasma blasts. And you can see that there's concordant activation of innate immunity with inflammatory cytokines and as surface and secreted markers of myeloid cell activation. In contrast, as you have heard already from Professors Casanova and Meyts, that adult severe COVID-19, really a proportion of these patients will have severely reduced or absent interferon signaling. However, this occurs in the context of hyperinflammation in other aspects of the immune system. When you compare to children with MIS-C, these adults will have increased spike-specific antibody responses as well as T cells, for example. So I would characterize adult severe COVID-19 as an example of immune dyssynchrony, where you have hyperactivation of certain pathways and mechanisms in conjunction with a severely reduced interferon response, which we have now realized is important for control of this virus. And this dichotomy really is what I see as one of the features that distinguishes the pediatric diseases from the adults. I will not go into the details of the impaired type 1 and 2 interferon signaling in adults, given that you have heard it directly from Professor Casanova himself. I put this slide with the symphony of papers that support this, this idea to show the contrast between this and what we have found in patients with MIS-C. So we have done whole exome sequencing now of over 150 children with MIS-C. This is done through multiple collaborations with the Overcoming COVID-19 study in the US, as well as the International Consortium for Immune Deficiency, which is a global collaboration. Thus far, what we have found is that children with MIS-C can have a monogenic variants impairing immune checkpoints. So I have highlighted 3 of them here. We have found variants in XIAP, which is on the X chromosome, as you know, and it is an inhibitor of the NLRP3 inflammasome. So in losing the regulatory effect of XIAP on NLRP3, we have shown in the published studies that this leads to an increase in IL-1 beta secretion and thus amplifies the inflammatory cytokine signature, since IL-1 beta itself can then induce interferon signaling as well as NF-kappa B signaling. Secondly, we have also found variants in CYBB, which are classically known to be associated with chronic granulomatous disease. And these are hypomorphic variants. And we have found that the DHR is, the oxidative burst is indeed impaired. And it has been previously published by Professor Casanova and others that variants in impairing this as well as other subunits of the NADPH oxidase can actually lead to an increase in interferon signaling, thus accounting for some of the inflammatory bowel disease, the lung disease that's associated with CGD. And thirdly, we have identified haploinsufficiency of SOX1. So SOX1 is a negative inhibitor of the JAK kinases that signal downstream of interferon alpha receptors 1 and 2. And so I've shown some of the data here on the right. In this particular patient that we have published, the patient has a very early frame shift mutation abrogating all functional domains of this protein, the KIR domain, which is important for control of the JAK kinases, as well as the SH2 domain and the SOX domain, which are important for control of NF-kappa B mediated inflammation. So looking at stimulation with either the type 2 interferon beta, type 1, I'm sorry, interferon beta, or the type 2 interferons here, interferon gamma, you can see that the patient with SOX1 haploinsufficiency has increased phospho-STAT1 signaling, shown here by phospho-STAT evaluation by FACS, compared to the control here, and also by transcriptomic analysis. So these genes here represent the type 1-2 interferon signature. This patient noted as the SOX1 het, you can see has a significant increase in the gene expression of this, which is more than the patients with acute COVID-19 shown here next to him, as well as the control. I show here on the far right a patient with genetically undefined but active MIS-C. So you can see that the signature is the same. Please note that the sample from the patient with SOX1 haploinsufficiency was taken after recovery with MIS-C, so that he is actually living in a state of inflammatory hyperinflammation that is similar to that which is seen in patients with MIS-C. So this patient with SOX1 did have some prior evidence of immune dysregulation with Evans syndrome and lymphopenia. However, I will note that the patients with XIAP deficiency, as well as the patient with the variant in CYBB, were really previously healthy before presenting with MIS-C, showing that truly hypomorphic defects can emerge with presentation of MIS-C. So one of the questions that is persistent since children, by and large, especially the young ones, have not received the vaccine is whether or not one is able to predict those children who may be at risk for this disease. So we took unstimulated peripheral blood mononuclear cells at least 7 months after recovery from either MIS-C or COVID-19. COVID-19 was a mild COVID-19, not requiring hospitalization. And we compared their resting PBMC transcriptional signature when they seemed ostensibly otherwise healthy. And you can see here from this transcriptional analysis that those with MIS-C have an increased expression of genes that are enriched in these inflammatory pathways, IL-18, oncostatin M, which is involved in interferon signaling, as well as type 1 interferon signaling itself. I show here the 3 patients with the genetically defined causes leading to their susceptibility to MIS-C compared to those with COVID-19. And you can see that these pathways really overlap. They are actually within those pathways that were identified by independent studies of patients who had active MIS-C. So all of this suggests that perhaps, at least for some patients with genetic susceptibility to MIS-C, that we may be able to see or anticipate the susceptibility through transcriptional studies of their, ostensibly healthy selves. And so finally, treatment of MIS-C. I show here just 2 papers, both in the New England Journal of Medicine. The first, again, coming out of the Overcoming COVID-19 study here, led by Mary Beth Sun and Adrian Randolph, where they found that treatment with IVIG and glucocorticoids was associated with a lower risk of new or persistent cardiovascular dysfunction than IVIG alone. So this is the algorithm that we follow here at Children's. Back to back, there was another study that came out of the consortium led by Mike Levine. And in this study, they found similar outcomes after treatment with IVIG only compared to glucocorticoids only, or the combination of the 2. They were looking broadly at all outcomes, but note that there are certainly differences in the populations here, this being based in the UK, and of course ours being based in the United States. And so the differences in the environmental exposures and in the genetic background of these individuals certainly contributes to some of these differences in the results. And so with that, I will close with many of the remaining questions because studies of viral infections of organized have identified potential reservoirs for SARS-CoV-2 of replication. These include the brain, astrocytes, the airway, the GI tract, the kidneys, and the endothelium. And all of these, with the exception of perhaps the kidneys, implicate organs that have been reported in more than one study of clinical phenotypes in children with MIS-C. And I have shown you the many studies that have characterized the immunophenotypes of this, but I would say sort of the real black box and the gap remains exemplified by this arrow. How do we get from the initial SARS-CoV-2 infection to MIS-C, which is this post-infectious state? We and many others are investigating this through studies of the genetic risk variants, through studies of organ and vascular permeability. There are likely environmental triggers, other infections perhaps, and pediatric obesity has emerged as one of the most common comorbidities associated in these otherwise healthy children. So we are studying that as well. And so to acknowledge the amount of work done on this disease is literally impossible. So I show on the left here, taken from the Nature Index, the collaboration that has really occurred during this pandemic throughout the world to generate data that has been shown in this talk and that extends far beyond the borders. I have listed here people at Boston Children's, those Mary Beth and Priya and Megan Day-Lewis, who have been leaders really in the rheumatology field here in characterizing, treating, and diagnosing MIS-C. Members in my lab and in the Division of Immunology as well, who have really been focusing on the genetic underpinnings of this disease, our international collaborators, and of course, Adrienne Randolph and the Overcoming COVID-19 network that she leads. Thank you very much.
Yeah, so we have two questions. Thank you very much, Janet, for that really magnificent talk. A lot of elaboration, and you have touched on many questions that we've been asking previously. We have a question here about whether you've measured the autoantibodies against the type 1 anti-interferons in this group of patients, and did any of these patients, that have been affected by interferon-related genes, or actually have any of the MIS-C patients eventually have affecting interferon-related genes? That's the first question. First two questions.
Yeah, so we are studying the type 1 interferon autoantibody question in collaboration with Mark Anderson and others in Stanford and the California universities. I will note that Professor Casanova's group and collaborators have a recent paper in Med where they did look in patients with MIS-C for autoantibodies, and at least in that paper alone reported that they did not find that. Same for us with we have certainly looked for those with deleterious variants affecting the production of interferon. We have not found that, but we've found sort of the counterpoint, so that what we have found are variants that impair negative regulation of the interferons. So severe COVID-19 is characterized by a loss of interferons. Thus far, what we have shown, which is just the beginnings, honestly, and others have other active studies. But what we have shown is that MIS-C may be the counterpoint, that is characterized by overactivation of interferon. And so that's sort of where we are now. But these cohorts are small. And so that's why we have these international collaborations, of course, to see if this holds out through multiple populations, genetic backgrounds, all of that.
Right. We have a couple more questions from Kate. So any speculations as to why we don't see MIS-C twice? Why doesn't it happen again? Or have you seen it? And one would assume that if you had the genetic risk, you would be at risk twice. So
I think that's an excellent question. So far we have not seen MIS-C twice. I have heard of patients who have tested positive after some time, maybe 6 months or later, after having MIS-C. So we will see what it shows out, but my hypothesis to explain that phenomenon is that as this is a disorder of hyperinflammation rather than classical immunodeficiency, they are mounting a good T cell response, a good antibody response, more than good, I would say, antibody response to this virus. And so with that, it may be enough to quell a secondary or tertiary infection. But we'd have to understand, I think, much more about how it is living in reservoirs and organs, and also the perfect storm of environmental triggers that are needed to precipitate this disease. So the odds that that storm is now encountered for a second time in the middle of a pandemic that is already unique in the history of humanity are low. So that's why.
And any differences between variants and waves?
No, not yet. So we and others have looked for that, whether that there's any specific viral variants. And the fact that it has actually occurred, throughout the world, but not predictably, it really correlates with the number of cases rather than the variant that is driving those cases.
And one last one, an apologetic one. Do you think that the vaccine-related myocarditis in children is related to MIS-C, or have it got a similar immunological phenotype?
Yeah, so I think that's a superb question, and we're studying that as well. Clinically, it is very different because most of the myocarditis, as you all know, is self-resolving. There are reports of more of a MIS-C-like phenotype after a vaccination. I would say clinically that perhaps resembles MIS-C more classically, but the mechanisms are extremely unknown, and so we will just have to say. But I would say that the ones with just simple myocarditis do seem distinct because it's really much more limited, one organ, and it resolves really without any immunosuppression. So thank you very much.
Thanks to you. Thank you very much for a magnificent talk and for all the elaborate answers that you've given. It's been a pleasure having you with us. Thank you so much, Janet. Thank you.
Thank you.
Yeah.
So we go on to the last speaker for the day. Should be quite exciting. I'm excited to introduce another speaker from South Africa, and that's Kate Webb. She's a pediatric rheumatologist, and she's also a current CRIC Africa Network Fellow. And her topic of research actually changed to this during the COVID-19 pandemic. So she's really got into this with her research topic, and we're excited to hear what she has found. Thank you very much, Kate. The topic is MIS-C in Africa. Where do we stand?
Yeah. Can I just ask everybody to ask Kate very difficult and many questions, because that's what she's been doing?
Will do.
Okay.
Thank you.
Thank you.
Good morning. My name is Kate Webb, and I would like to thank you very much for inviting me to speak today. And I'd like to discuss the research that we've been doing on the novel multi-system inflammatory syndrome related to SARS-CoV-2 in children in Cape Town. So as you all know, this was a syndrome that was first described in about April of 2020, when the first cases started to emerge in the UK, and cases were quickly recognized throughout the world, including in Europe and the US. And we published the first case series of our cases in August of 2020. And the WHO released a definition of MIS-C towards the middle of 2020, where they spoke about children and adolescents who were 0 to 19 years old. They had to have had a fever for at least 3 days, and either a rash, hypotension, or shock, quite strong features of myocardial dysfunction or heart disease, clotting problems, quite severe gastrointestinal problems like diarrhea, vomiting, and quite a severe abdominal pain. And these kids had to have evidence of raised inflammatory markers and no other cause for these symptoms, and evidence of exposure to COVID-19, either through empirical evidence such as a test or likely contact with patients with COVID-19, which was useful in our context because we had very little access to testing at that stage. So very recently, the US has published these data, which is an estimation, the first estimation of the incidence of the syndrome in children. And they estimate that there's an incidence of about 2.1 per 100,000 children in the population. But obviously, this is very different between states, and these are really early preliminary data. As you can see here, the red dots represent MIS-C cases, and the shading represents the cases of COVID-19, and they don't always correlate here, and this is probably because of the structure of the pandemic, and in places with a high burden of MIS-C, perhaps initially they weren't testing children as much in the first few waves, and that's changed as the pandemic's gone on. So we really don't know very much about MIS-C or how common it is, and these data look at MIS-C in the general population, but not in children who've been exposed to SARS-CoV-2. So we don't know yet the risk of developing MIS-C if you're exposed to SARS-CoV-2 as a child. So between June of 2020 and the end of March of 2021, we started to recruit these patients as soon as we started to see them at the Red Cross Children's Hospital and the Tygerberg Hospital, which are the two main pediatric referral centers within Cape Town. And we recruited 69 patients with confirmed MIS-C between the two centers over this time period. As you can see, we had 2 COVID peaks during that time period, and on average, the peak of cases of MIS-C followed the peak of cases of COVID by about 4 to 5 weeks, which is in fitting with previous literature. It must be said that each wave that we have had in South Africa has been led by a distinct variant. So we saw relatively fewer cases in the second wave, and we're still gathering the data as we're coming out of our third wave now. The patients who developed MIS-C in Cape Town are reflected here. So out of those 69, there was a median age of about 7. And what we were able to do at the same time is to recruit patients who we called inflammatory controls. So these were children who presented to casualty, and MIS-C was on the differential diagnosis list. So they eventually turned out to have some other diagnosis that was more plausible. And these included children who had TB, typhoid, dysentery, sepsis, appendicitis, and other infections. And we recruited 23 of these children during the same time period, and they formed quite a useful comparator group. We also recruited children with Kawasaki disease and healthy children, and 96 healthy children presenting for elective surgeries during this time. So as you can see, the median age of MIS-C was about 7. That matched the children who were coming with other inflammatory disorders. Patients with Kawasaki, we recruited 8 of them, tended to be much younger, and healthy children were similar to those children who had MIS-C. We saw a relative overrepresentation of children of Black African origin in the MIS-C group as compared to the other groups. At the same time, we recruited 96 children, as I said, from who presented for elective surgeries, and we found that about 1/3 of these children had detectable antibodies. So we don't have enough data yet to show any patterns as it relates to the waves, And we had to shut down recruitment over December when elective surgery stopped locally. And at some stages during the pandemic, during peaks, they've stopped elective surgery. So these data are interesting and show about a 30% seroprevalence, which is reflected in other data from the province. But we don't think are enough yet to show any patterns. But these form a very important group, these children who are exposed to SARS-CoV-2 but haven't developed MIS-C, to compare to those children who have. So in Cape Town, about 69 patients with MIS-C, only 22% of them had a confirmed contact. So someone that within the family had any kind of sickness or febrile illness within, and been PCR positive within the last month. About 17% had someone in the family who was unwell, but surprisingly, almost 60% of children had no one that they knew of who had been unwell or had COVID. And 10 out of 69 were PCR positive, but almost all of our patients were serology positive. So we analyzed the presenting features of the patients with MIS-C, their clinical features, and not surprisingly, because it's an entry criterion, 100% of them had fever. Almost 98% had tachycardia, 84% had rash, 76% had a conjunctivitis, 60% of these children had severe abdominal pain, and almost 60% of them had hypotension or diarrhea. So it's quite a non-specific presentation, which made us interested to see how can we look at this within an emergency room setting. So we compared these to the 26 patients, apologies, who presented as a suspected MIS-C, but turned out to have another diagnosis. And when we used a logistic regression model, we found that tachycardia, having a fast heart rate or tachycardia, the presence of a rash, and the presence of conjunctivitis, all independently associated with that child being more likely to be MIS-C than a differential diagnosis. Of the patients with MIS-C, almost a third had renal disease, so that's any form of renal disease, and 4 of the patients required dialysis. Almost a third had CNS disease, and this included things like seizures, decreased levels of consciousness, a hemiplegia that was reversible. Almost a third of the patients had some form of lung disease, and 16% of patients met the criteria for a macrophage activation syndrome. In terms of the heart disease, 17% of patients had a pericardial effusion, and almost 6% of our patients had coronary artery aneurysms in the initial stages, but none of them had coronary artery aneurysms on follow-up. And more than a third of them had mitral regurgitation. So they have a much more significant cardiac disease when you compare them to inflammatory controls or children with Kawasaki disease. And that's reflected here by the ejection fraction, which tells us about the functioning of the heart as a pump, really. And you can see the patients with MIS-C had a median ejection fraction of 52% as compared to children with other infectious or inflammatory disorders, which was 65%, and that was a significant difference. And we went on to compare the patients who were inflammatory controls to those with MIS-C in order to investigate whether we could find any laboratory features that might, in the first instance, try and help us to differentiate these patients. So what was interesting is the patients with MIS-C did not have a significantly different CRP to patients who are inflammatory controls, making it not that useful in terms of distinguishing between the two. But they tended to have lower hemoglobin, higher neutrophils, higher ferritins, and quite profoundly lower minimum platelets. So a median platelet count of 187 as compared to 340, which is quite clinically significant. And these patients also tended to have quite low sodiums compared to patients with who are inflammatory controls. Equally, they had much higher cardiac markers like TROP-T and BNP as compared to inflammatory controls, which was interesting because in pediatrics, we don't use these cardiac markers much. So we were unsure what they meant in inflammatory controls, but we've shown that data nicely now. What we think is interesting and useful in this is not necessarily the hemoglobin. We were looking for a test that was easily available and something that could help people discriminate. And what we're working on now is looking at a mix of the platelets and the sodium to help discriminate in the first instance, or at least to alert clinicians to the possibility that there may be MIS-C if you do have a low platelets or a low sodium, together with some of the other clinical features. So we went on to perform a gene expression analysis in patients with MIS-C as compared to healthy controls. because we had sufficient numbers of both of those groups to do this analysis. And we worked with SATVI, who's the South African TB Vaccine Initiative, who had a panel of 84 immune genes that they had a multiplex PCR on. So they were very kind to be able to run this, and this is on whole blood RNA. And we analyzed healthy patients who were and were not exposed to SARS-CoV-2, so those who are antibody positive and negative, as compared to patients with MIS-C. And you can see that there's a really distinct expression of immune genes between these two subsets. But when we look at it more closely, this first box represents the first time point in patients with MIS-C. So these are children who have not received any therapy for MIS-C. This is MIS-C in the acute phase. So you can see a really distinct expression of immune genes here. This is the second time point. So these are patients who have received some therapy, usually 2 to 3 days later. And then these are patients either on discharge or on follow-up, so who have completely become well and are following up. And what we see is in this first box over here, an expression of some genes that very quickly turns off with treatment. So from day 0 to day 3 or 4 post-treatment, or even day 2 in some instances, we see that the expression of IL-1 beta, IL-27, and genes like IL-10 very quickly switch off. And then we have a second signature here, you can see in the second box, that seems to persist even after treatment, but resolves a little bit later on follow-up. And that includes genes like TLR8, TGF-beta, NOD2, MMP9. And then a third subset of genes that only becomes overexpressed post-treatment. So is relatively underexpressed on the first day, but increases the expression post-treatment. And this includes things like MMP9. And then, of course, we have the subset of genes on the bottom here that are relatively underexpressed as compared to healthy children and gain their expression again once these children seem to get better. And this includes, surprisingly, IL-6, interferon gamma, and all of the type 1 interferon-inducible genes such as MCP1, and MX1. So we don't think that this is a type 1 interferon gene expression predominantly. What was interesting from these data is this gene expression seems to normalize with treatment in MIS-C. So we have in red here on our PCA, these are patients, apologies, with MIS-C at baseline. Then these children receive treatment either with IVIG and Medrol or with IVIG alone. And we can't really tease out a difference between these yet on these data. But the black represents patients on follow-up with MIS-C, and the green are patients who are healthy. So we see a complete resolution with time, which is what we see clinically in these patients once they get better. What we've also been able to show is the next thing we looked at in association with the National Institute for Communicable Diseases in South Africa was to see if there were any differences in antibody titers or how these antibodies behaved in patients who developed MIS-C as compared to healthy children who we know are exposed to COVID but didn't develop MIS-C, in order to try and tease out whether there was anything inherent in antibodies that were predisposing these children to develop MIS-C. And what we can see here is the patients with MIS-C had exactly the same titers of antibodies towards spike protein as compared to children who were exposed to COVID or SARS-CoV-2 but didn't develop MIS-C. And equally, there's no difference in the titers of antibodies towards nucleocapsid antigen in children with MIS-C as compared to those who are healthy and exposed but didn't develop MIS-C. What we did find is that there was a trend towards, there was a trend towards better neutralization in patients with MIS-C as compared to those who were exposed to COVID and didn't develop MIS-C. So these antibodies tended to be better at neutralizing SARS-CoV-2. And equally, when we looked at the function, the FC effector function of these antibodies, we found that there was an improved capacity for antibody-dependent cellular phagocytosis. So the antibodies were better able to induce phagocytosis in kids who had developed MIS-C as compared to healthy children who were exposed but did not. But there was no difference in the antibody-dependent cellular cytotoxicity score. So we're doing further work here to try and investigate whether this improved neutralization or phagocytosis may be related to antigen exposure or whether it's related to the general inflammation that makes these antibodies kind of behave better in a way. So going on to the treatment of the patients that we've had locally, almost all of our patients have received IVIG, 94%, 64% have received methylprednisolone, and 60% have received both. About a third of patients have only received IVIG, and very few patients, only 2 out of the 69, only received methylprednisolone, with a small subset requiring an IL-6 inhibitor with tocilizumab. So this is the real question in MISC, is, and especially in an African context, is IVIG better than methylprednisolone, or are both of them better than either one? Or are any treatments better than no treatment? We simply don't have the data at the moment to be able to make those determinations, which are really important. What we do know is that, and I've put IVIG just as time points arbitrarily on the bottom here, I'm not trying to show a causal relationship to effect, but what we do know is that with time, and when these children do turn around and when they do get better, their CRPs completely normalize and they do extremely well. We're working with a group in the UK and Swiss groups, and I'd be interested if anyone wants to join us from the rest of Africa to set up the recovery arm, the recovery trial, to try and investigate which treatments are the best for ICU. So we're going to stratify by severity. If these children require ICU, then we are going to randomize them to either get IVIG or IV methylprednisolone. And if they don't require ICU, so they're not severe, we're going to randomize them to receive IV methylprednisolone, IVIG, or supportive care alone. So hopefully we can get some randomized data that will support treatment decisions in these patients, especially in contexts where IVIG is not easily available. So of the patients that we've seen, these 69 patients, about a third of them required inotropes, a third required oxygen, and about a third required ICU. But luckily to date, we haven't lost any patients who have presented to the hospital. We're not sure whether that is true in terms of patients who may have died without a diagnosis or in the periphery. And as you can see here, the outcomes of the duration of stay, we hope that we did a little bit better on the second wave, but we have got some patients who stayed for at least 3 weeks. So we're looking at the trends of whether our interventions or times to diagnosis have improved patient outcomes, but we simply don't have those data as of yet. So in summary, we've got a good MIC cohort from Africa, and I think the only published so far to my knowledge, and I'd be interested to hear from your experience. And we've got a detailed clinical data set with matched samples and controls. We've shown that about 30% of our healthy children have antibodies to SARS-CoV-2, and we've shown that there is a trend towards a better neutralizing capacity and induction of phagocytosis in patients who have MISC. And our gene expression shows a complete resolution of the abnormal gene expression in these patients initially. We're working with many groups to try and improve what we know about MISC. So we're working with the Diamonds group to look at some personalized RNA signatures and try and tease out better how we could diagnose these patients. We're looking at comparing seasonal coronavirus immunity in these patients as compared to patients who don't develop MISC. We're looking at T-cell responses, TCR repertoire profiling, because there's been some evidence that there may be a super antigen response in these patients. Whole genome signature, whole genome sequencing. And what we really want to do is develop a risk profile for these patients so that we can predict who may develop MISC and what the risk factors look like and what these children look like. I'd just like to mention quickly vaccination, and I think it's been a concern of many of us since the very beginning, is this antibody mediated, is this antibody induced? And if antibodies are inducing MISC, could vaccine-induced antibodies cause MISC? So this was something that we were worried about from the beginning. The CDC in the US is one of the first to, the US is one of the first that has started to vaccinate younger people, and they're vaccinating children from 12 to 15 currently. They have reported cases of myocarditis that occur very rarely in younger adolescents who have been vaccinated with their second dose of usually an mRNA vaccine. These cases do not seem to be similar to MIC in that they don't seem to have the same associated features like rashes and fevers and and abdominal pain that we've described in MIC, but we're really not sure whether the two are linked yet, and we continue to watch this closely. In the UK, they've started to offer 1 dose of vaccine to children older than 12, and in the US, the CDC has elected to continue vaccination. And I want to stress that these are very rare effects, and I think will be interesting to look at in the future whether they relate to MIC at all or not. And my feeling is probably that vaccination is going to protect children from MIC more than it's going to predispose them to MIC, but this is work we need to do, especially in the African context, where we have much higher rates of population who are younger than in other countries. So you can see here, this graph reflects the proportion of the population who's less than 14 years old. So if we're going to achieve meaningful coverage in terms of vaccination in our population groups, we really need to vaccinate younger people. And we're going to need to know a lot more about what causes MIC and what the risk factors are in terms of making good decisions about how we vaccinate our population. So I'd just like to thank everyone who's been involved in this study, and I'd like to encourage people to contact us if they have cases and if they'd like to be involved in any of the research we're doing. Thank you very much.
Thank you very much, Kate. Lovely and insightful talk, and hopefully there will be connection coming from the rest of Africa for this, because as you've shown, we need lots more data for this, and especially for now going forward to vaccination of younger children, which we need. We do have some questions here, and I've got one myself as well. There's one saying, what type of PID was more common in patients with MIS-C or MIC? I think that was to Janet still. Kate, I don't know if it was addressed in your study at all.
Yeah, we didn't have any patients with PID in our smaller group. I'm not sure if Janet wants to speak to that.
I mean, in terms of MIS-C, so far we've found just defects in immune disorders that are hyperinflammatory disorders. So more of the chronic granulomatous disease, SOX1 haploinsufficiency, and XIAP deficiency.
Thank you. And then another question that came up to Kate, actually directly, what do you think is the cause of the hyponatremia in these patients?
I'm gonna dodge this one by saying I'm not sure.
You can throw it back at Janet.
Yeah, I'd like to know what you think. But I think why I stress the hyponatremia is we want to find out, what's really easily available in our context. And what we find quite attractive is platelets and sodium, because the majority of places can do that. I think a lot of places wouldn't be able to get a neutrophil count. It's possible you wouldn't have access to serology. And I think we've really had to struggle to just get BNPs, and we're a kind of major tertiary center. So for us, if we could look at sodium and platelets as being an accessible way, just for people to think, this might not be a straightforward typhoid if the platelets are low, or to even in terms of platelets, try and differentiate a little bit between MIC and Kawasaki, that's really looking at.
Yeah, I think it's fascinating because you may be already hitting upon a mechanism of pathophysiology that's not really been described before. Is the sodium taken before they receive anything, any IV fluids, so that chemistry is done before any intervention, is that right? Oh, so that's very interesting.
Yeah. Yeah.
I have another question with the third wave that we've seen here in South Africa and also in the rest of Africa. Have you also seen children that develop MIS-C now in the acute COVID stage? It's been reported. So in other words, it's almost part and parcel of the presentation.
Oh, sorry, Monica, I've missed that question.
Yes, I think you froze there. I'm asking with the Delta variant, our most recent waves also across Africa, and that have you seen children presenting now very early on with MIC, in other words, more in the acute COVID phase, which has been reported now?
Yeah, I mean, sorry, I missed quite a bit of your question, but I think it speaks to variants. And this is something I wanted to discuss with you, Janet, because, in South Africa, we had a relatively small first wave that was wild type. We had a huge second wave, which was beta, and a much bigger third wave that was delta. And we saw a definite decrease in MISC on the second wave, and we're just coming out of the third wave. But we certainly, I don't think, and we're still analyzing these data, haven't seen the amount of cases we saw in the first wave. So, everyone always asks us why we're seeing less and less, and perhaps we underestimated how many kids were exposed to COVID in the first wave. We didn't have as much adult hospitalizations of COVID. So we don't think that we underestimated the third wave the first as compared to the second and the third. But I've always been interested to watch the US and other data to see if there's been any differences with variants. To explain why we seem to have, I think, less with each wave, but we'll still see.
Yeah, I think that's a hard question to answer because there's so many variables. The lack of testing, at least for us here, was a huge thing. So I have no idea actually how many cases there were in the beginning because we were purposely not testing children, actually, even if the whole household had COVID-19, we just assumed that they did. So I think that's one huge variable. And then the second is that the genetic background is so different as well. So I think we'll see, maybe in a year or so when we all have a bit more data, right, how that all pans out.
Thank you. We've got no further questions here. Nala, do you see any more questions? Have we missed something?
Well, there's just one that's come.
One popped in, yes?
Yeah, from Rashida.
Do you want to take that one and conclude then?
Yeah. So do you have patients with negative PCR and no epidemiological link? Is that, I just didn't understand the first one, DIX.
Yeah, I think what Rashida is trying to ask is, we had the same problem, is that we have a patient with a negative PCR and absolutely no one in the household who's been unwell, no one who's tested, no granny who's had a fever in the last month or a cough or anything like that. And so when the WHO came out with a likely contact, we took that to mean that you were in an area with a high community transmission. So that's probably, it's being a bit loose with our definition. But on many of those patients, we collected serum at the time, and we've only subsequently, all of the MIC data that I showed, those patients have all been confirmed on, well, the majority of them on serology. So I think that in our context, we may be more likely to have patients who are within a household who may not have access to testing. And because we have really widespread community transmission, especially in South Africa at some stages, we had a 25% positivity test rate. So I think that we just assumed that the child had exposure. And it will be really interesting going forward when 30% of our healthy children have had exposure that we know of from now. So whether serology will be useful at all moving forward in our context, we don't know yet.
Many difficult questions. Well, yeah, thank you very much, Kate. It was a very nice presentation, very informative. I did miss part of it because I was called for some organizational dilemmas, I wouldn't say issues. But thank you so much. I think that was a phenomenal session exploring COVID and comparing what we see in Africa and the beautiful quality of data. So it's magnificent. Thank you very much. I'm sure that COVID is changing epidemiology of disease, as I said earlier, and it is going to affect how we look at immunology, perhaps as much as HIV did at some point. I mean, we have seen a lot of even diagnostic tests coming up, methods improving. So it's yet another change, big change in science, and a big leap for immunologists. So thank you very much. You've given us a very good insight into all aspects that you've displayed. So we are appreciative of your presence with us, and for all the information you gave us. Thank you so much. And I think that was a fantastic end to the day. What do you think? Amazing.
Thank you for a great session.
Yeah, wonderful. Thank you.
Thank you. Bye-bye.
Okay,
bye.
bye.
Thank you.
Bye. Thank you. Bye.
Bye now.